organizer of this summit, and they have slotted a slot on clinical sciences, Ayurveda and traditional medicine and specialist care for the meaningful discussions and the brainstorming sessions today. So with the interest of time, now I would like to move on for the presentations. So both of us has very privilege to welcome you and honor you here. So firstly, I would like to request presenter Usha Singh. Her works on prevalence, trends and determinants of low birth weight in Nepal, a pooled analysis of NDHS 2011 to 2022 data with multiple imputations. So may I would like to request ma'am to present her works ahead. Thank you.
Okay. Thank you, Dr. Puspa. Good morning, everyone. मेरो नाम उषा सिंह र मेरो
So before that, I would like to welcome and introduce our presenter with the all distinguished gathering over here. Ms. Singh is an monitoring and evaluation and data analysis professionals with extensive experience in managing large-scale quantitative and qualitative studies across Nepal. She holds a master's degree in research methodology. She has conducted descriptive and inferential statistics analysis for multiple national health survey. She has authored 5 peer-reviewed articles. With that very brief note, now I would like to hand over the podium to Usha ma'am.
Thank you. ल्यापटप नै ल्याएर आज Good, good morning, everyone. Ma Usha Singh. Very boy. Uh, Again, good morning, everyone. मेरो study को title है Prevalence, Trends and Determinants of Low Birth Weight in Nepal, a pooled analysis of India's data, Nepal Demographic Health Survey data 2011 to 2022 with multiple imputation रहेको छ। यदि बच्चाको वेट चाहिँ 25 बच्चा जन्मिँदाखेरि यदि बच्चाको वेट चाहिँ लेस देन 2500 ग्राम छ भने त्यसलाई चाहिँ लो बर्थ वेट भनिन्छ। ग्लोबली 15 देखि 20% चाहिँ बच्चाहरू चाहिँ लो बर्थ वेट जन्मिन्छन्, त्यसमा पनि 50% जति चाहिँ बच्चाहरू चाहिँ लो एन्ड मिडल इन्कम कन्ट्रिजबाट हुन्छन्। लो बर्थ वेट चाहिँ डाइरेक्टली चाहिँ नियोनेटल र इन्फान्ट मोर्टालिटीसँग चाहिँ एसोसिएटेड छ। तर डेभलपिङ कन्ट्रिजको हकमा कुरा गर्ने हो भनेपछि चाहिँ हेल्थ फेसिलिटीको डेटा युज गरेर प्रेभलेन्स लो बर्थ वेटको प्रेभलेन्स एस्टिमेट गर्न चाहिँ अलिकति बायस हुन जान्छ, किन भन्दाखेरि यसले चाहिँ सबसेट डेटालाई मात्र रिप्रेजेन्ट गर्छ र धेरै जस्तो होम डेलिभरीहरूलाई चाहिँ यसले एक्सक्लुड गर्छ। त्यस कारणले चाहिँ हाउसहोल्ड सर्वे डेटाले चाहिँ हाउसहोल्ड सर्वेहरूले चाहिँ बर्थको इन्फर्मेसन चाहिँ कलेक्ट गर्न थाल्यो, तर हाउसहोल्ड सर्वे डेटा पनि लिमिटेड भयो, किन भन्दाखेरि धेरै जस्तो बर्थ वेट चाहिँ जन्मिने बेलामा चाहिँ होम डेलिभरीको कारणले गर्दाखेरि चाहिँ बर्थ वेट चाहिँ ननापेको भएर आमाहरूले चाहिँ बच्चाको बर्थ वेट पनि न्युमेरिक बर्थ वेट पनि चाहिँ भन्न नसकेको भएर त्यो पनि हाउसहोल्ड सर्वे डेटाहरू पनि लिमिटेड भयो। अनि त्यो सँगसँगै एनडिएचएस 2022मा चाहिँ लो बर्थ वेटको प्रेभलेन्स पनि क्यालकुलेट भएको छैन। त्यस कारणले यो स्टडीको अब्जेक्टिभ भनेको चाहिँ पहिला सुरुमा चाहिँ एस्टिमेट मिसिङ बर्थ वेटलाई चाहिँ एस्टिमेट गर्ने मिन्स अफ इम्प्युटेसनको थ्रुबाट जुन मिसिङ बर्थ वेटहरू हुन्छ त्यसलाई चाहिँ इम्प्युट गर्ने, त्यो सँगसँगै चाहिँ त्यो एस्टिमेट भएको बर्थ वेट र अभाइलेबल बर्थ वेटलाई चाहिँ कम्बाइन गरेर चाहिँ प्रेभलेन्स आइडेन्टिफाई गर्ने। र अर्को भनेको चाहिँ 3 इयर्सको चाइल्ड डेटा सेट चाहिँ 3 इयर्सको डेटा सेट युज गरेर चाहिँ ट्रेन्ड लो बर्थ वेटको ट्रेन्ड र फ्याक्टर्स एसोसिएटेड चाहिँ लो बर्थको चाहिँ सँग चाहिँ फ्याक्टर्स के हो त्यो एसोसिएटेड फ्याक्टर्स त्यो चाहिँ आइडेन्टिफाई गर्ने। डेटा सेट चाहिँ युज भएको चाहिँ एनडिएचएस 2022को 2016 र 2011को डेटा सेट युज भएको छ र स्टडी भ्यारिएबलमा चाहिँ डिपेन्डेन्ट भ्यारिएबल बर्थ वेट हो र इन्डिपेन्डेन्ट भ्यारिएबलमा मदर्स एज एट चाइल्ड्स बर्थ, मदर्स एजुकेसन, मदर्स बडी मास इन्डेक्स एन्ड एएनसी भिजिट ड्युरिङ प्रेग्नेन्सी, कन्जम्सन अफ आइरन ट्याब्लेट्स ड्युरिङ प्रेग्नेन्सी, प्यारिटी, बर्थ इन्टरभल, कुकिङ फ्युल एन्ड चाइल्ड सेक्स, एथनिसिटी, प्रोभिन्स, रेसिडेन्स एन्ड वेल्थ इन्डेक्स। यसमा अक्जिलर भ्यारिएबल पनि भनेर हामीले साइज एट बर्थ पनि युज गरेका छौँ। र यो स्टडीमा चाहिँ स्टडी भ्यारिएबलको चाहिँ क्याटेगोराइजेसन चाहिँ प्रिभियस स्टडीहरूमा भएको सिमिलर स्टडीमा भएको क्याटेगोराइजेसन चाहिँ हामीले यो स्टडीमा चाहिँ युज गरेका छौँ। अब यसमा चाहिँ मेरो फर्स्ट अब्जेक्टिभको लागि चाहिँ प्रेभलेन्स आइडेन्टिफाई गर्नको लागि हामीले चाहिँ एनडिएचएस 2022को डेटा सेट युज गरेको थियौँ। त्यसमा चाहिँ अन्डर 5 इयर्सको चिल्ड्रेनहरूको चाहिँ 5372 रेकर्ड छ। त्यसमध्ये पनि बर्थको इन्फर्मेसन मात्र भएको चाहिँ 3177 जना बच्चाहरूको इन्फर्मेसन छ। मल्टिपल बर्थ्सहरू चाहिँ आर लाइकली टु ह्याभ लो बर्थ वेट। त्यसमा 34 जना चाहिँ बच्चाहरू चाहिँ मल्टिपल बर्थ ट्विन्स भएको भएर तिनीहरूको लो बर्थ वेट आफै हुने भएको कारणले गर्दै तिनीहरूलाई एक्सक्लुड गरेर सिङ्गलटन बर्थ चाहिँ 3141मा हामीले एनालाइसिस गरेको। त्यो 3141 मध्ये पनि 37%को चिल्ड्रेनको मात्र कम्प्लिट रेकर्ड छ भनेपछि 63%को चिल्ड्रेनको कुनै न कुनै हाम्रो स्टडी भ्यारिएबल चाहिँ एउटा न एउटा चाहिँ मिसिङ छ। अनि त्यो मिसिङलाई चाहिँ हामीले चाहिँ मल्टिपल इम्प्युटेसनको थ्रुबाट चाहिँ एड्रेस डेटा चाहिँ इम्प्युट गरेको। अब ट्रेनको लागि चाहिँ 10 इयर्सको डेटा सेट ओभर द 10 इयर्समा 3टा इयरको चाइल्ड डेटा सेट युज गरेर हामीले ट्रेन एनालाइसिस गरेछौँ। यसमा 2011 र 2016 र 2022 2011 र 2016मा चाहिँ 2011मा हेर्न सक्नुहुन्छ धेरै जस्तो मिसिङ बर्थ वेट चाहिँ 2011मा छ, त्यो चाहिँ 63.3%, फलोड बाई 2016मा चाहिँ 38.7 छ र 2022मा चाहिँ 20.8% छ। अनि यो चाहिँ 2011 र 2016मा चाहिँ अन्डर 5 इयर्स बच्चाकोहरूको चाहिँ बर्थ वेटको इन्फर्मेसन छ भनेपछि 2022मा चाहिँ बच्चाको इन्फर्मेसन चाहिँ लेस देन बर्थ वेटको इन्फर्मेसन चाहिँ लेस देन 2 इयर्सको मात्र बच्चाको भएको कारणले गर्दा हामीले चाहिँ यो स्टडीमा चाहिँ लेस देन 2 इयर्सको बच्चाको बर्थ वेटको इन्फर्मेसन मात्र लिएका छौँ र त्यो कम्बाइन गर्दाखेरि तिनवटा वर्षको चाइल्ड डेटा सेट चाहिँ कम्बाइन गऱ्यो भने टोटल 10,115 चिल्ड्रेन रेकर्ड्सहरू हुन जान्छ। अब प्याटर्न यो हाम्रो चाइल्ड डेटा सेट यो चाहिँ 2022को डेटा सेटको मात्र कुरा हो। त्यसमा चाहिँ मिसिङको यो फिगर ए र फिगर हेर्न सक्नुहुन्छ। फिगर एमा चाहिँ पर्सेन्टेज अफ मिसिङ कति छ र फिगर बीले चाहिँ प्याटर्न कस्तो मिसिङ डेटाको प्याटर्न कस्तो छ भनेर डिनोट देखाउँछ र फिगर एमा हेर्न सक्नुहुन्छ धेरै जस्तो मिसिङ चाहिँ बर्थ वेट र बिएमआई मदर्सको बिएमआई भ्यारिएबलमा र बर्थ वेटमा मिसिङ छ भने फिगर बीमा चाहिँ यो ग्रे बक्सले डिनोट के गर्छ भन्दाखेरि यो भनेको फिगर बी भनेको कम्प्लिट रेकर्ड हो। त्यो चाहिँ 37%को मात्र कम्प्लिट रेकर्ड छ चाइल्ड रेकर्ड छ भनेपछि रेड बक्सले चाहिँ मिसिङ डिनोट गर्छ र रेड बक्समा हेर्न सक्नुहुन्छ धेरै जस्तो चाहिँ 36.78% भनौँ त्यो चाहिँ भ्यारिएबल मदर्स बिआईमा मिसिङ छ र 9.4% चाहिँ बच्चाको चाइल्डको रेकर्ड चाहिँ बर्थ वेटमा मिसिङ छ र 9% जति चाहिँ चाइल्ड रेकर्ड र उसमा मिसिङ छ बिआईमा र बर्थ वेटमा। अनि यसको प्रेभलेन्स स्टडीबाट चाहिँ 2022को स्टडीबाट चाहिँ प्रेभलेन्स चाहिँ ओभरअल 11.8% ओभरअल लो बर्थको प्रेभलेन्स 11.8% थियो र फ्याक्टर्स सच एज मदर्सको बिएमआई र मदर एएनसी भिजिट ड्युरिङ प्रेग्नेन्सी चाहिँ सिग्निफिकेन्टली एसोसिएटेड देखियो। र ट्रेन हेर्ने हो भनेपछि प्रिभेलेन्स अफ लो बर्थको चाहिँ ओभर द 10 इयर्स पिरियडमा चाहिँ 14% 2011मा थियो भने 11.9% चाहिँ 2022मा चाहिँ देखेको छ। ओभरअल हाउएभर द ओभरअलमा चाहिँ पर्सेन्टेज चाहिँ डिक्रिज भयो तर स्ट्याटिस्टिकली चाहिँ ओभर द पिरियडमा चाहिँ स्ट्याटिस्टिकली चाहिँ सिग्निफिकेन्ट छैन। अब यो ट्रेन्ड्सहरू हेर्दाखेरि ट्रेन्ड्स अफ लो बर्थ वेट चाहिँ वेल्थ इन्डेक्स र मदर्सको एजुकेसनमा हेर्नुहुन्छ भने 10 इयर्सको पिरियडमा पोरहरूमा चाहिँ सिग्निफिकेन्टली ड्रप भएको छ। नियरली 17%देखि चाहिँ तपाईँको 13%सम्म चाहिँ डिक्रिज भएको छ भनेपछि लो बर्थ वेट पोरमा चाहिँ। त्यस्तै गरी यहाँ नो एजुकेसनमा हेर्न सक्नुहुन्छ 16%देखि चाहिँ झन्डै 11.5%सम्म चाहिँ सार्पली डिक्रिज भएको छ लो बर्थ वेटको प्रिभलेन्स। ट्रेन्ड्स अफ लो बर्थ यसमा बडी मास इन्डेक्स र बर्थ इन्टरभलमा ट्रेन्ड्सको लो बर्थ वेटको ट्रेन्ड हेर्दाखेरि यसमा ओभरवेटमा हेर्न सक्नुहुन्छ ट्रेन्ड चाहिँ इन्क्रिज भइरहेछ बर्थ वेटको इन्क्रिज भइरहेछ भने अरू सब ग्रुप जस्तै नर्मल र अन्डरवेटमा चाहिँ बर्थ वेट चाहिँ ट्रेन्ड चाहिँ घटिरहेछ। र यो चाहिँ ट्रेन्ड्स अफ लो बर्थ वेट एएनसी भिजिटर जेन्डर अफ चाइल्डमा हो। यसमा चाहिँ हेर्न सक्नुहुन्छ ओभर द पिरियडमा 10 इयर्सको पिरियडमा मदर्स हु ह्याड द लेस देन 0 to 3 भिजिट्स चाहिँ ओभरअल चाहिँ हाई नै छ लो बर्थ वेटको प्रेभलेन्स भनेपछि कम्पेयर टु हु ह्याड द के अरे मोर देन 4 एएनसी भिजिट्स। अनि यसमा हेर्न सक्नुहुन्छ ओभर द पिरियड 10 इयर्सको पिरियडमा जेन्डर मेल र फिमेलमा चाहिँ ओभर द पिरियड 10 इयर्सको पिरियडमा घटे तापनि तर जेन्डर चाहिँ दुईजनाको कम्पेयर गर्दाखेरि फिमेलमा चाहिँ ओभर द पिरियडमा चाहिँ जेन्डर फिमेलमा चाहिँ हाई नै छ। यो चाहिँ यो ट्रेन्डमा चाहिँ हेर्दाखेरि 3 इयर्सको कम्बाइन्ड डेटा सेटमा चाहिँ बडी मास इन्डेक्स बर्थ इन्टरभल एएनसी भिजिट ड्युरिङ प्रेग्नेन्सी र जेन्डर अफ बेबी चाहिँ यिनीहरू चाहिँ सिग्निफिकेन्टली चाहिँ लो बर्थसँग चाहिँ एसोसिएटेड छ त्यो चाहिँ आइडेन्टिफाई भएको छ यो स्टडीबाट। ल कन्क्लुजनमा चाहिँ कुरा गर्ने हो भने चाहिँ मिसिङ डेटालाई चाहिँ ह्यान्डल नगरिकन सिधै केस डिलिसन गरेर एनालाइसिस गरेर प्रेभलेन्स चाहिँ एस्टिमेट गर्नुभन्दा चाहिँ मल्टिपल इम्प्युटेसनको थ्रुबाट चाहिँ यदि इम्प्युट गरेर प्रेभलेन्स एस्टिमेट गर्नु भनेको रिजल्ट चाहिँ अनबायस्ड हुन्छ र सरी है कता गयो ला सरी ल सक्यो पनि थ्याङ्क यू। तर कन्क्लुजनमा छ Although more second line मा चाहिँ although modest progress has been made over the period होइन decade, low birth remains significant concern, particularly among the undernourished mothers and those with the inadequate ANC utilization. Strengthening maternal nutrition, promoting adequate birth spacing, and ensuring at least 4 ANC visits are critical to further reducing low birth weight and improving neonatal outcomes in the Nepal. Thank you. यति नै हो.
Thank you, Usha Singh ji, for a very powerful presentation on the very relevant topics on public health. So similarly now I would like to request Dr. Satya Narayan Yadav for his works. Let me introduce him. Dr. Satya Narayan Yadav has completed his PhD degree in public health from Mahidol University, Thailand, with postgraduate degree from Tribhuvan University. He has strong academic training in public health and research. He is currently an assistant professor and program head in Department of Public Health, Madhes Institute of Health Science, Janakpur Dham. So the podium is over to you, Dr. Satya, for your works.
Thank you. Respected chairs, delegates, invitees, and ladies and gentlemen. It's me, Dr. Satya Narayan Yadav. Currently, I am working as the assistant professor at the Madhes Institute of Health Science. Today, I will present about my research finding that determination of the factor influencing the performance of the community health volunteer, especially FCSB, use of the self-determination theory. It is the one of the research finding based on the analysis of the self-determination theory as the construct factors and how these factors are associated with their performance by using the confirmatory factor analysis and SEM model. So this is all of our pairs. So as we know that SDG is malaria is the one of the target or eradicate the malaria by the 2030 at the under the SDG goal, one of the target goal, but still we have the big problem about the one about the 3 million population are at the risk of the malaria among the 83 endemic countries. Nepal is also one of the prone country. In Nepal, about eight districts there is a prevalence of high malaria region, basically in the endemic regions including Lumni, Karnali and Sudar Paschim. Still now this is one of the threat of the malaria. So still we have also a strategic plan and we have to try to eliminate the malaria strategic plan by the 2030s, but still we have also the community health approach. At the community health approach we have the FCSB. They are trained and have to do about the sevens role at the community levels. They have to basically identify the case, refer the case, transferring the knowledge and try to record and report the case to the health authority. But still we as the theory revealed that performance is the not only gaining the knowledge and skills, but they need to also support. This is the performance theory by the different context. But one of the theory is the very popular in the performance behavior, that is the self-determination theory. Self-determination theory is revealed that autonomy, competency and relatedness is the one of the key factor to identify the performance behavior. So this study try to identify those types of determinants. That is the first type of the study that try to find out the causal relationship between performance and construct determinants by the self-determination theory. So this is all over of the objective. We try to find out the assessment of the performance and describe the performance in the terms of their autonomy, leadership, competency and relatedness, basically social support and their relationship with the performance. So basically this study used the including socio-demographic factors. So individual factors and the environmental factors. Environmental factors, this theory revealed that we have to need some types of support. That might be from the social support, from their individual level or community level or their supervisor levels. And this is the overall of my research methodology, quantitative and cross-sectional study. I used about the 1,204 FCSB of the endemic regions, and altogether there are the altogether there is a 1,070 hundreds FCSB. Among them, constantly we use the 1,204 sample. So this is the area that a study was conducted. This is a high endemic area. We can see that as per the malaria microfication survey, the incidence of malaria parasite is more than 1 in that area. That study area was taken for the study. So inclusion criteria and exclusion criteria. This is overall the sampling frame. Firstly, the all of the our sample was taken at the proportionate to the size and sample random sampling was used for the further. This is the survey instrument for socio-demographic, and the second one is the work motivation. 20 items of work motivation scale was used for the determine the work motivation at the community levels. And the second one is the leadership. 4 dimension 12 items was used to determine their leadership, and the 10 items of the self-efficacy was used to identify their self-efficacy scale, and the 5 social support scale was used as the that was consist 5 component, and the last one, that outcome variable was the performance. 7 items, 7 dimension with 21 items was used to determine their performance. So this is all overall the reliability of the scales. And during the statistical analysis, this study was for the descriptive SPSS was used, but for the causal relationship SPSS MS graphic was used to determine the conformity factor analysis and further structure equation model. So we have the different index chi-square and divided by the degree of freedom, and also we have the different composite variable and their standard scale that determine the equation model between them. So ethical consideration was basically obtained from the NHRC. Regarding the background informations, this is the basically median age was basically 40 years old. Most of them are involved in the agricultures, and regarding their experience, most of them have the more than the 5-year experience, and the monthly income was the low, that is consists 1,050 hundreds in that area. So this is all the overall level of the performance. So about the 50% of the FCSB have the good performance. However, still there is a room to improve the performance, basically in the treatment and also in the somehow in the referral cases, and also in the identify the cases they have the low. So this revealed that this is similar to the Thailand and the Myanmar, but however more than the Cambodia and the Laos. This is the overall score of the motivations, leadership, self-efficacy, and the overall of the different types of leadership. We can see that about the every level of the score is near to the 50%. However, motivation among the different types of motivation, autonomy motivation found to be the reveal the high level of the level among the FCSB. And also social support, we can see that supervision with the good feedback was the high among the FCSB. This is just to identify the chi-square. We can see that basically education and the experience as the FCSB were the non-significant. Then other things like older age, major occupation as agriculture, more experience, refresher training, family support, some types of leadership, and also some types of the more family support was associated with the performance. But when used for the conformity analysis, we have the initially we have the 5 items and the 57 constructs, but after using the structure equation model of each, among the 12 we only find the 3 construct and 9 items of the motivation basically. So this is the one of that, because we have the standard criteria to identify the measurement model, and also measurement of the leadership was the very significant with the results. And regarding the self-efficacy, 10 item, only 8 item is significant with the performance. Regarding the social support, only family support and community support and the supervision support were the significant with the performance. And the correlation revealed that this significant is the very constant with the performance. And the structure equation model revealed that basically we can see that motivation, leadership, and the some type of support was the highly associated with the performance, about 40% of the significant the performance. But however, we can see that also like the motivation, leadership, and social support was indirectly associated with the self-efficacy. So this is the one of the factors that identified by the social structure equation model. It revealed that self-efficacy itself not like a major factors, it is one of the mediating factors. So this is the one of the model revealed that after the adjusting this model associated with the self-determination theory, we can see that motivation and the some type of support is the very associated with the performance. However, self-efficacy performance can be moderate to vary their performance. So this is the one of the model. After the final analysis of the model, after the we can see that 57 item, only the some item of the motivation, leadership, and social support, but moderate with the self-efficacy is the associated with the high performance of the community health volunteer. So takeaway message that this is the first level of the national study, because this study was conducted for the endemic area and whole district was included. But among this, self-efficacy is one of the most important factor to reveal by this model. So government should be identify these factors and try to make the confidence level building training to support the community health volunteer. Even autonomy among the motivations, self-directed motivation like the autonomous motivation is one of the identify the key factor to enhance their performance. Not all leadership style, but we have to change the types of leadership while focus on the different tasks. So this is one of the recommendation for the policy level. We should reform the or create some types of policy that might to help to the training building, capacity building to enhance their performance. But as a community level or the implementation level, encourage the community health volunteer basically to support their work and to maintain their work at the social level, including their individual level, like year of experience. If more experience regarding some types of area, they might be help to their more performance. And major occupation as the agriculture, then the other occupation was the most significant. So this is one of the selection area while we have to focus on this area. But the policy and implementation level, we have to focus on the more on the autonomy, but as well as their self capacity building. So this is all. So I would like to thank my university, all my professors, and not least but a community health volunteer who support the doing data collections. Thank you.
Dr. Jaya Satyal holds MD and PhD in acupuncture. She is affiliated with Ayurveda Hospital Nardevi and Annapurna Neuro Hospital. She practices and contributes to integrative and acupuncture-based clinical care. Dr. Satyal, Jaya Satyal.
Thank you. First of all, I would like to thank the organizer for giving me this wonderful opportunity to share my findings. The title of my study is The Effect of Electroacupuncture in Neurogenic Bladder, a quasi-experimental study. We all know that the neurogenic bladder is a dysfunction of either the urinary bladder or bladder neck or its sphincter due to the disease of peripheral or central nervous system disease. And there are mainly two types. One is the overactive bladder and the another one is the underactive bladder. And talking to the prevalence in Parkinson's disease, it is about 38 to 71%. In multiple sclerosis, it is about 40 to 91%. And in spinal cord injury, it is about 70 to 84%. And stroke and other diabetic neuropathy, it is about 15%. And in Chinese medicine, the neurogenic bladder is termed as long P. Here the long means dribbling and the P means blockage. And this disease is first mentioned in Huang Ti Neijing. It is also known by the name of Yellow Emperor. It is a Chinese ancient book. Let's see the micturition control. We all know that the micturition process is controlled by cortical micturition center and also the pontine micturition center and spinal micturition center. There are many literature review. All studies show that the electroacupuncture is very, very useful in the case of neurogenic bladder, in underactive bladder and also in overactive bladder. Why we do this study? Because we all know that neurogenic bladder results the long-term disability, and there are many treatment modalities like anticholinergic medicine, spinal management, Botox injection, and neuromodulation. But all these modalities do not have a satisfactory result. So we need to establish the effectiveness of electroacupuncture in the case of neurogenic bladder. The main general objectives of my study is to determine the efficacy or effectiveness of electroacupuncture in improving the symptom of neurogenic bladder. So it is the hypothesis of my study. The alternative hypothesis is that integrated therapy of electroacupuncture combined with other management has a very good or effective result in case of neurogenic bladder. And for my study, the age, gender, type of neurogenic bladder, and then the neurological disease are taken as a independent variable, while the bladder management, daytime frequency, saturation of pad, number of pad, nocturia, high incontinence, longest interval, interval without leakage, screen problem, nocturia, straining, stream, post-void fullness, and U-type frequency and quality of life are taken as a dependent variable. It's let's see the methodology. It is a quasi-experimental study, and it is a non-randomized convenient sampling. The sample size is 60, 30 in experimental group and 30 in control group. And the duration of treatment was 3 weeks. These are the study site. One is the Ayurveda Hospital Nordebi and the another one is the Annapurna Neurological Hospital. Let's see the methodology. For methodology, we divide the acupuncture point in 3 groups. यो भनेर चाहिँ अब जस्तो एउटा चाहिँ नियर बाई पोइन्ट्स भनेको जुन जुन ब्ल्याडर को एरियामा पर्छ तिनीहरूलाई भनेको हो र त्यो बाहेकको अर्को चाहिँ जस्तो डिस्टेन्ट पोइन्ट भनेको कतिपय चाहिँ अकुपोइन्टहरू हाम्रो लोअर लिम्बमा पनि पर्छन् जस्तो हामीले पोस्टर टिबियल नर्भलाई स्टिमुलेट गर्ने हो जुन हाम्रो चाहिँ लोअर लिम्बमा पर्ने पोइन्टहरू छन् अथवा हातमा पर्ने पोइन्टहरू छन् तिनीहरूलाई चाहिँ हामीले डिस्टेन्ट पोइन्ट भनेर भनेका छौँ र त्यो बाहेक डाइरेक्टली चाइनिज मेडिसिनमै इन्क्लुड गरेको युरिनेसनसँग सम्बन्धित पोइन्टहरूलाई चाहिँ हामीले सिम्प्टोमेटिक पोइन्ट्स भनेर चाहिँ भनेका छौँ र यसमा मेन इलेक्ट्रो अकुपन्चर चाहिँ सबै पोइन्टमा हामीले इलेक्ट्रिकल स्टिमुलेसन दिँदैनौँ इलेक्ट्रिकल स्टिमुलेसन चाहिँ मेनली भनेको यो एब्डोमिनल पोइन्टहरूमा हाइपोग्यास्ट्रिक नर्भलाई स्टिमुलेट गर्न र अर्कोमा चाहिँ स्याक्रल फोरामिनमा पर्ने पोइन्टहरू त्यसमा सबैभन्दा स्ट्रङ पोइन्ट चाहिँ एउटा छ ल्याओ भनेर भन्छ चाइनिज मेडिसिनमा त्यसमा चाहिँ हामीले स्टिमुलेट गरेका हौँ र इलेक्ट्रो अकुपन्चर चाहिँ 6 टाइम्स अ विक फर 3 विक्स र along with conventional therapy चाहिँ हामीले दिएको हो. अब यसमा चाहिँ कस्तो छ भने we all know that हैन, oh there are two type of bladder problems, one is overactive and underactive bladder. For the same problem we select the same occupants, but the only the difference is that the manipulation technique. For overactive bladder we use the reducing manipulation technique, and for underactive we use the reinforcing manipulation technique. यो भनेको छ निडलको manipulation technique मा भर पर्छ. एकदम हाई फ्रिक्वेन्सी दिनेवालाले चाहिँ रिड्युसिङ टेक्निक भन्छ भने स्लोसँग बिस्तारै 1 मिनेटमा 30 to 40 पर्नेलाई चाहिँ रिइन्फोर्सिङ टेक्निक भन्छ. त्यो मात्रै डिफरेन्ट हो. र यसमा चाहिँ अब ग्रुप 1 जुन कन्ट्रोल ग्रुप छ, कन्ट्रोल ग्रुपलाई हामीले पहिले ओभर एक्टिभ र अन्डर एक्टिभ भनेर चाहिँ डिभाइड गर्यौँ र क्याप्सुल चाहिँ युरिम्याक्स चाहिँ दिइरहेको थियो र टाम्सुलोसिन हामीले दिइरहेका थियौँ भने अन्डर एक्टिभ ब्ल्याडरको केसमा चाहिँ सिआइसी क्लिन इन्टरमिडिएन्ट क्याथेटराइजेसन अथवा कुनै बिरामीको हकमा भनेको इन्डोलिङ क्याथेटर चाहिँ गरिएको थियो. र अब यसमा त यो मेरो स्टडीको इन्क्लुजन र एक्सक्लुजन क्राइटेरियाहरू हो. This is the conceptual framework for my study. For outcome measures, हामीले चाहिँ NBSS score use गरेका थियौँ. It has a good reliability and validity. Let's see the results. This shows that in both group, control and experimental group, most of the participants fall at the age group of 71 to 80 years, and similarly most of the participants below are male in both cases. त्यस्तै गरेर कज अनुसार हेर्यो भने धेरैमा चाहिँ दुईटै कन्ट्रोल र एक्सपेरिमेन्टल दुईटै ग्रुपमा हेर्दाखेरि स्पाइनल कज चाहिँ सबैभन्दा बढी देखिएको छ न्युरोजेनिक ब्ल्याडरको. र यो चाहिँ ब्ल्याडर म्यानेजमेन्ट प्री एन्ड पोस्ट ट्रिटमेन्ट कम्पेरिजन छ. यहाँ चाहिँ हामीले के हेरेको छौँ भन्दाखेरि जस्तो क्याथेटर लगाइरहेको बिरामी छ भने क्याथेटरबाट क्याथेटर आउट हुनको लागि कतिको इम्प्रुभमेन्ट देख्यो त्यो अनुसार चाहिँ गरिएको छ. र यसमा हेर्दाखेरि जुन हाम्रो एक्सपेरिमेन्टल ग्रुप छ त्यसमा 17% जुन हाम्रो ग्रुपमा चाहिँ 17% 56% थियो भने पछि आफ्टर अकुपन्चर 3 विक्स पछाडि चाहिँ 0 मा झरेको देखिएको छ. भनेपछि there was a significant improvement was seen in case of bladder management. Similarly incontinence मा चाहिँ हामीले लिएको भेरिएबलमा डे टाइम फ्रिक्वेन्सी, स्याचुरेसन अफ प्याड, कतिवटा प्याडहरू भिज्यो, बेलुका कतिचोटि उठ्यो, नम्बर अफ प्याड कतिवटा चेन्ज गर्यो, स्किन प्रब्लमहरू के हो, यो सबैलाई हेरेको थियौँ. यसरी हेर्दाखेरि पनि जुन इन्कन्टिनेन्सको सिम्पटम चाहिँ आफ्टर ट्रिटमेन्ट 3 विक्सको ट्रिटमेन्ट पछाडि चाहिँ एकदमै सिग्निफिकेन्ट इम्प्रुभमेन्ट चाहिँ देखिएको छ. त्यस्तै गरेर स्टोरेज र भोइडिङ प्रब्लममा चाहिँ हामीले फ्रिक्वेन्सी अफ युरिन, अर्जेन्सी, नक्चुरिया, लङ्गेस्ट इन्टरभल कति हो त, अनि स्ट्रिम कस्तो छ, पोस्ट भोइड फुलनेस कति छ भनेर हेरेको थियौँ. यो हेर्दाखेरि पनि अकुपन्चर ग्रुपमा चाहिँ सिग्निफिकेन्ट इम्प्रुभमेन्ट चाहिँ देखिएको छ. र कन्सिक्वेन्सेसमा चाहिँ हामीले जस्तो लङ टर्म न्युरोजेनिक ब्ल्याडर भयो भने के हुनसक्छ त, युटिआई हुनसक्छ र अर्कोमा भनेको स्टोन हुनसक्छ, पेन हुनसक्छ. यसमा हेर्दाखेरि पनि अकुपन्चर पाएको ग्रुपमा चाहिँ एकदमै सिग्निफिकेन्ट इम्प्रुभमेन्ट चाहिँ देखिएको छ. र क्वालिटी अफ लाइफ हेर्दाखेरि पनि क्वालिटी अफ लाइफमा पनि इलेक्ट्रो अकुपन्चरको ग्रुप चाहिँ एकदमै सेटिस्फाइड, आफ्टर ट्रिटमेन्ट चाहिँ एकदमै सेटिस्फाइड चाहिँ देखिएको छ. र यो हाम्रो फाइन्डिङहरू चाहिँ अगाडिका जति पनि इलेक्ट्रो अकुपन्चरसँग भएका स्टडीहरूको जस्तै नै खालको चाहिँ रिजल्ट चाहिँ देखिएको छ. र हामीले के भन्न सक्छौँ भने कन्क्लुजनमा चाहिँ इलेक्ट्रो अकुपन्चर चाहिँ एकदमै ब्ल्याडरको केसमा एकदमै इफेक्टिभ छ र कन्जर्भेटिभ म्यानेजमेन्ट सँगसँगै इलेक्ट्रो अकुपन्चरलाई गर्यो भने चाहिँ राम्रो रिजल्ट पाउन सकिन्छ. र यसको लागि हामीले इथिकल क्लियरेन्स चाहिँ एनएचआरसीबाट लिएको थियौँ. र लिमिटेसनमा चाहिँ के छ भने हामीले यो स्याम्पल साइज सानो छ र चाइनाभन्दा नेपालमा गरेको भएर कतिपय इलेक्ट्रो अकुपन्चरको जुन म्यानिपुलेसन टेक्निकमा अझै पनि गाइडेन्स नपुगेको जस्तो अनुभव हुन्छ र लङ टर्म फलोअप खासै गरिएको छैन. र अर्कोमा भन्दाखेरि चाहिँ अब हामीले चाहिँ इन फ्युचरमा चाहिँ लङ टर्म फलोअप चाहिँ एकदमै जरुरत देखिन्छ भने अर्कोमा चाहिँ डबल ब्लाइन्डेड ऱ्यान्डमाइज कन्ट्रोल ट्रायल चाहिँ नेसेसरी चाहिँ देखिएको छ. र अन्तमा चाहिँ म मेरो प्रोफेसरहरू डाक्टर पन्त र कुवै दुवैजनालाई धेरै धेरै धन्यवाद दिन्छु र यहाँहरूलाई पनि एकदम राम्रोसँग सुनिदिनु भएकोमा धन्यवाद.
धन्यवाद. Next, I would like to invite BP Bipin Ghimre, how physiotherapists and orthopedic surgeons manage patients with knee osteoarthritis in Nepal. Nationwide cross-sectional study. Bipin Ghimre is a lecturer and musculoskeletal physiotherapist at Kathmandu University, School of Medical Sciences, Dhulikhel Hospital. His academic and clinical work focus on physiotherapy education at bachelor's and master's levels. His research interest in osteoarthritis with emphasis on evidence-based care and implementation in Nepal. Bipin Ghimre.
Thank you, Chair. I would like to thank NHRC for giving me the platform to showcase my research. So my title is How Physiotherapists and Orthopedic Surgeons Manage Patients with New Osteoarthritis in Nepal, a nationwide cross-sectional study, and this is my team. So what we already know about osteoarthritis, it is the leading cause of pain and disability worldwide, including in Nepal. And a study done on chronic pain has shown that knee osteoarthritis is the leading cause of pain in Nepal. And then the prevalence of osteoarthritis, though this is not the national prevalence, it has done in the eastern part of Nepal, and it has shown that 41% of individuals above 65 years of age are affected with osteoarthritis. And then the number of patients with osteoarthritis is projected to rise significantly by 2050. That has been projected by the Global Burden of Disease. And a review done by Jillian Isles and Saurabh, orthopedic surgeon and physiotherapist are the primary healthcare providers for the management of osteoarthritis. They have reviewed that in from the low and middle income perspective. So our objectives, knowledge gaps, and focus of our studies. Though we know orthopedic surgeon and physiotherapist are the two primary caregiver for the osteoarthritis, but we don't know how do physiotherapists manage patients with osteoarthritis in Nepal, and in parallel, we don't know how do how do orthopedic surgeons manage patients with osteoarthritis in Nepal. So we try to run the parallel survey among those two professionals and then find out to understand their management strategies. That was one objective, and another objective is either those treatment strategies are aligned with the internationally published clinical practice guidelines or not. So what we did, we developed and validated two surveys from the expert as well as from the literature review from the similar kind of survey studies conducted in other countries, and we have validated that questionnaire through the face and content validity by the 5 experts from each professionals, and also validated through the content validity index. And we have pilot tested those 2 questionnaire before implementing in a nationwide for the 10% of the sample. Though it was exploratory nature of the study, we did not know actual participant. However, we anticipated around 85 to 90 orthopedic surgeon based on the study previously done by orthopedic surgeons to understand the orthopedic surgeons management practices. And we the method of our survey is survey administration. Initially we planned to do the Google form survey only, online survey. However, the responses rate was very low and we had to adopt that methodology by utilizing the pen and paper based survey as well. And data analysis, so I'm just giving the snapshot of the data analysis so that within this short period of time the key messages is conveyed to the audience. So I'll be analyzing my research data based on these summary of osteoarthritis clinical practice guidelines. There are multiple osteoarthritis clinical practice guidelines available in the literature. However, most of them the treatment recommendations are not same. So Bimbi Gray et al. From the University of Sydney, they have done the review of osteoarthritis clinical practice guidelines, and these are the picture here shows all the clinical practice guidelines are agreeing with these concepts. So I will be analyzing my report through based on these treatment strategies. For the core management strategies is the education for self management, physical activity and exercise, and weight management, irrespective of the diagnosis, either in different stages or in the severity of the stages. These are the core concept. All the clinical practice guidelines convey this message, and strong recommendation to use the topical NSAIDs and yoga and tai chi. For the conditional recommendations, oral NSAIDs, corticosteroid injections, walking aids and assistive device, manual therapy and thermal therapy. And the strong recommendation against the treatment are arthroscopy and opioids. So who will be considered guideline concordant or guideline adherence? I may use this term interchangeably. So please remember the color code as well. The green, if the participant rated always or mostly for core and strongly recommended treatment, they are considered as guideline concordant. For the conditional recommended treatment, if they responded mostly, sometimes or rarely, so they will be considered as guideline concordant. And for rarely and never for the treatments with strong recommendation against their use. So what we found for physiotherapy survey, so total of 145 physiotherapists, 50% of them were female, participated in this study, and majority of them had their bachelor as their highest academic degree. So this also represent the relatively new field of physiotherapy in Nepal, and nearly 3/4 of them had less than 5 years of working experience. We also asked either they were aware of any osteoarthritis clinical practice guidelines. This question was kept at the end of survey to reduce the cognitive or the selective bias. So 70% of the physiotherapists were aware of one or the other form of osteoarthritis clinical practice guidelines. However, significant number, 30% of them were not aware of any clinical practice guidelines. So for core and strongly recommended treatment, 100% of them were guideline concordant for exercise prescription, 70% of them for self-management, and 74% of them for weight management. And for the Tai Chi, only 8% of them were guideline concordant, and I don't want to blame they are not guideline concordant, because it also signifies the cultural differences in the selection of the management strategies. Tai Chi is an exercise that has been initiated from the Chinese medicine, and that is not adapted in all countries. For the conditionally recommended treatment, walking aids and assistive devices, 60% of them were guideline concordant, 77% is for the manual therapy, and 56% of them were for thermal therapy. So treatments with strong or conditionally recommended against the use, most of the clinical practice guidelines recommend treatment with electrotherapy against their use. That means clinical practice guidelines are not recommending electrotherapy for the management of osteoarthritis. I would like to highlight this point. And only 10% of the physiotherapists were guideline concordant. That means they were majorly using these kind of treatment strategies. For the orthopedic surgeons, 85 orthopedic surgeons participated in the study, and half of them also had less than 5 years of experience. And for the orthopedic surgeons, only 45% of them were aware of any clinical practice guidelines. There's a significant gap. And for core and strongly recommended treatments, referral to physiotherapy for exercise, 100% of them, self-management 60%, and almost 100% is for the weight management. For conditionally recommended treatment, 61% is for the NSAID, and 96% of them for the corticosteroid. They were guideline concordant. So for the treatment with strong recommendation against their use, only 43% of orthopedic surgeons and 55% of orthopedic surgeons were guideline concordant for the arthroscopy and opioids. That means many of them are still using that. So conclusion, what are the key takeaways? I have just given the snapshot. However, we are analyzing this data. We have other treatment strategies that they have also reported. So considering the time limit, I just mentioned the key findings. So the majority of healthcare professionals are guideline concordant for the core and strongly recommended treatments such as exercise and weight management. However, many of them do not adhere to guidelines for the treatment strongly recommendation against their use such as electrotherapy, opioids and arthroscopy. So our recommendations in the study which I am currently conducting, the continuous professional development programs such as arthritis training, learning and upskilling that emphasize the evidence-based osteoarthritis care may enhance the adoption of recommended intervention and reduce the reliance on non-evidence-based practices. Thank you. I am on time.
धन्यवाद. Next presenter, I would like to invite Professor Dr. Binod Kumar Yadav, impact of genetic polymorphism in vitamin D pathway related GNS on vitamin D status in human health, evidences from local studies in Nepalese population. Professor Dr. Binod Kumar Yadav is MS, Medical Biochemistry, PhD Medical Science, and postdoctoral fellowship Neuroscience, and currently working as Registrar and Professor Biochemistry at Madhesh Institute of Health Sciences, Janakpur Dham, Madhya Pradesh. He is permanent faculty of Biochemistry of Maharajganj Medical Campus, Institute of Medicine, Tribhuvan University, Kathmandu, Nepal, since 2005. He has published more than 60 research articles in reputed international and national journals. He has worked as member of editorial team, member of Journal of Nepalese Association of Laboratory Sciences 2010 to 2012, and currently is Annal of Clinical Chemistry and Laboratory Medicine and in the Meds Alliance Journal of Medicine and the Medical Sciences. Dr. Professor Binod Kumar Yadav.
Thank you for the introduction. Vitamin D, as you all know, is nowadays mostly requested test in all of the clinics. So today I am talking simply from the local study why these are things done and what is its importance over here. So vitamin D, as you all know, it is one of the fat soluble vitamin, and we are getting every day in any form of the diet, mostly the fat containing diet, and most of the cells have their receptors, but still we are in the deficiency state all over the world, not only the Nepal. So it is synthesized naturally, we can say, with the help of sunlight, wherever we are even in the rich source of the sunlight in the Nepal. But even we are in the deficient state, so what may be the cause? So we are looking for that. So daily recommendation for this SARC country is generally 600 to 800 internal unit, and it is even going to be by age. So we know, I am not going to drill over here, it is synthesized. Most prevalent source is the sunlight with the help of our skin. That is, skin you can see the exposed sunlight, and liver and kidney are the two major organs which is playing the role in the synthesis of the vitamin D. So here I will not in details because this all know their metabolism. So these are the pathway you can see how they are going to be synthesized. In this one you can see the liver and the kidney, and the skin is the three main organ which is going to be play. If there are the enzymes, you can see over here the SHIP enzyme, the cytochrome P40, then hydroxylase enzyme in the liver and the kidney. So these two organs playing the role basically in the whole metabolism of the vitamin D synthesis in our body. So these are the again different forms of the vitamin D available. We know vitamin D3 is the more active form, but still we are getting the vitamin D from the different diet source also, and even whatever the other source we can get, but this is ultimately D3 is our active role. And these are the different organs, they are playing the role in the metabolism and utilization of the vitamin D. So these are the, again, saying the importance role of the vitamin D, that we see the vitamin D3 calcitol. We can see over there, most from top to bottom our the body structure, every organ, every part is the important getting the from the vitamin D. So that's why we are looking for the role of the vitamin D, and even we are always behind that, the vitamin D level in our blood is how much. So this is again different role. Now it is again most commonly who are the at the risks. So this you can see over here, this is the people with the limited exposure to the sunlight, overweight people, pregnant women, elderly people, and dark skinned people also. So that might be one of the cause we may have somehow, but not always that one. So again they can see. So these are the not our studies. These are the data, these are the value given that you can say in very clinical terms the reference interval. But this reference interval is not from our population. Still, by using this data, there are so many studies have been done in the Nepal, and they have, most of them studies are the hospital based study. So some clinic based study, and they all have shown, some of the studies shown more than 90% deficient state. So we are not even going on that one, but why we have planned, we have studied 2 population based study in the Nepal also. So that you can see, I am not in detail, this all study had shown the deficiency state over here. So with that studies, we conclude that there should be some population based study has to be done. With this, already we have thought not only this one, they can say these 2 studies had been done in the Nepalese population. One is the Bagmati Pradesh, and the next one is the Madhya Pradesh. These 2 studies had shown even the reference interval also in that population, and by comparing to that, the level of deficiency or the level of insufficiency is even severe in all group. So even we are thinking, we are in the state of the, mostly you can say that we have very good sun exposure. Even most of the we are working in the sunlight environment, not even that we are the burqa users. So why again we can say what may be the cause, and even we are not in the state, we are not getting the sufficient food also. We are in the situation, not only you can say the poor only we have included in that one, you can say that maybe the malnutrition, it is not a state. So even when we go for the population based study, that give us some little bit lower side of the that USA study base. So this data is shown over here. We can see this is the one type of the comparative study you can see, or even in the population based study, we have this level of the vitamin D in our population. But the same time we cannot make generalized statement because this is not throughout our country. So what you can see over here, whatever the state, whatever the condition, so sometimes we have to think out, not always, some of, not only can say this is somehow reference interval we are saying, but there are nowadays the modified term reference interval decision limit. So now whatever the value we have to decide by the clinician when you have to prescribe vitamin D. Not only vitamin D, all of the biochemical test, all of the laboratory test, whatever we have the reference interval, this is not always deciding factor. The decision done by the clinician, when you have to start or not to start. Some people may have vitamin D level 20, he may need the vitamin D supplementation. Some people may have the vitamin D 15, he or she may not need the vitamin D. So that depends decided by the clinician. So nowadays it is a modified reference interval decision limit, you can say. The IFCC is one of the organization, the working for the clinical chemistry reference interval, they are deciding this way, and they have given the message to all the clinicians. So not always you go for that reference interval value. You decide the patient whatever the condition over there. So this way, this study. Now still we are looking for, when we study the population, then we are thinking not always this the nutritional deficiency over there. There might be some other factor. So that factor is one of these things. You can the pharmacogenetics or even the personalized medicine. In that one, we look for the most important gene which is playing the role in vitamin D metabolism. So here there are so many genes, but our team has chosen 3 genes. In among them, one gene which is metabolizing in the vitamin D, the another one that is the vitamin D receptor, that transportation one, and the next one is there is a group specific, again playing the transportation of this. So you can see over the CYP gene and GC gene and this BDR gene. So we have chosen among these different 3 sites, this 3 group of the gene has been chosen to study their genetic polymorphism. That means where they are lying, which form of these genes are present and what their association with the vitamin D. So at the time is going over, so I am just showing these are the genotyping. Molecular studies have been done, all these 3 sites, and now I will be coming on the differences over here. You can see. So here this one, like say simply you can say the GC group specific, which is playing the role in the membrane transfer. So here you can see these 2 sites are not different. Even their differences of the different gene type that not shown the level of differences. So it doesn't mean you can't say why the studies have been done. So this is always there is a chances. Not all genes are sensitive, but you can see the other studies. Here this is all not one, but next one you can see. This is the another one that show the difference level of vitamin D. So this is the here you can see the level of the vitamin D again. This 3 different forms of vitamin D, even you can see the here this vitamin D receptor, this hydroxylase enzyme, which is playing the role in the liver, and this you can see here the AG type has different level of the vitamin D with individual. So this again you can say, and this is again giving the message not always the diet, not always the environment. Sometimes there are some genes which playing the role. That means we are, this is by the birth, this is by the birth. We are not changing over here. I have the some another type, you have some other type. So person which bearing this gene variants may have different level of the vitamin D level. So that's the same way others studies here again this is the significantly different. So not all types, but there are, we have found among the 6, 3 have been showing the different level of the vitamin D. So ultimately what we can say, if this study showing not the only diet, we are whatever focusing for the diet, sometimes we have looked for that there are genetic factors, genes, individual genes, which is nowadays comes under the pharmacogenetics, or you can say nowadays personalized medicine. That is for, there are so many studies have been done, not only the vitamin D, even nowadays the cancer medicine is given on the basis of this genotyping. So this way you can say these are the, this is the factors may be playing the role in individual that have the different vitamin D level. So the recommendation with this study, especially for the clinician, when you are going to prescribe the vitamin D, first you decide when the patient are really in the need, because it cost money and even cost very high. Even the general medicine you can go, you can buy easily vitamin D tablet, everybody is getting over there, but you have to think when we have to give or not to give. And even there we have sometimes think for not only because of other factors, sometimes it may be the genetics role playing the role over there. So this is the basically take home message for the today discussions, and thank you so much as I passed my time. If any questions, I would love to answer, or even at the break time.
Thank you, Professor Dr. Vinod Kumar Yadav, for presenting a very urgent public health need in the society. So similarly, now I would like to invite our speaker, Dr. Lily Rajvanshi. Dr. Lily Rajvanshi is an assistant professor. Assistant professor at the National Academy of Medical Sciences and a specialist in cataract, vitreoretina, and retinopathy of prematurity. She serves as the head of the Vitro Retina and Quality Department at Viratnagar Eye Hospital. In addition to her clinical and academic roles, she is currently an executive board member of Nepal Health Research Council, contributing to national health research and policy development. So now the podium is over to you, ma'am.
Thank you so much, Chairs, and good afternoon, everyone. Today, I'm going to talk about the eye disease, diabetic retinopathy. This is one preventable blindness of in ophthalmology, in which the physicians have a first and very important role for preventing blindness. So, before sorry, how to go back? Back then. Sorry. So, before going to the topic proper, I would like to briefly tell about the disease. Diabetic retinopathy is a microvascular complication of diabetes that affects the retina and can lead to the vision loss or blindness if not detected early. And retina is a innermost thin, highly vascularized retina, so diabetes very easily affects it. So, talking about the pathophysiology briefly, chronic hyperglycemia does the pericyte loss and basement membrane thickening, and that leads to the capillary dropout, and that causes the retinal ischemia. Due to ischemia, there will be the VEGF upregulation, and that causes the neovascularization and vascular leakage. There will be also neurodegeneration process occurring. So, there are basically two types of diabetic retinopathy. Less severe is the non-proliferative diabetic retinopathy, and the more severe is proliferative diabetic retinopathy. The main theme, our main motto should be not to let patients to develop proliferative diabetic retinopathy, and that can be done with screening and the observation. So, non-proliferative diabetic retinopathy is again further subdivided into mild, moderate, and severe on the basis of the area involved. And now this is the picture of proliferative diabetic retinopathy. When if not detected early and not treated, then it can there can be a vitreous hemorrhage due to the neovascularization and severe ischemia, and also the proliferative membrane, which can pull the retina, leading to the tractional retinal detachment. The other entity is macular edema. When there is a leakage of the increased permeability of the vessels, there will be the accumulation of fluid in the macula, which is the fine area for the vision formation. So, regarding the prevalence of diabetic retinopathy, 8 to 10% of people are diabetic in Nepal, according to the different studies, and whereas among them 10 to 20% have a diabetic retinopathy, and vision threatening diabetic retinopathy is seen up to 24%. Risk factors besides diabetes are high blood pressure, pregnancy, family history, race, and high cholesterol. Symptoms will be they are asymptomatic till until very late, but if when this develops and it becomes severe, then there can be blurred vision, loss of vision, floaters, and dark spots. So treatment are anti-VEGF in the form of injection. Laser therapy is done to ablate the ischemic retina and the preserve main posterior pole of the fundus. And if not, if it develops to proliferative retinopathy, then surgery is advised. Why it should be detected early, or early detection or screening is matters. Diabetic retinopathy remains a leading cause of preventable blindness. Preventable blindness is a good news for us, because if we find them early, then we can prevent it. So, patients often present late with diabetic macular edema or proliferative diabetic retinopathy. Early stage disease means best visual outcomes with minimal intervention, and economic and surgical burden also decreases with early detection. Early detection, early diabetic retinopathy has no symptoms, so it is the scary part. People come late because of that, and vision may remain normal until advanced stages. Patients come late with macular edema, vitreous hemorrhage, and tractional retinal detachment, like I showed in the pictures. And what will be the physician's role today? My motto is to tell about to our respected physicians. They have a more first and important role, because patients come to them before us, and sometimes they don't even show up to the ophthalmologist because they don't feel its need. So they can ensure the early fundus examination, refer early even if vision is normal. They can emphasize glycemic control, especially the HbA1c control. Blood pressure control is also equally important in diabetic retinopathy control, and lipid control as well. They can counsel the high risk group, for example long standing diabetics, pregnant women, and those with poor metabolic control who require close monitoring. And also they can document eye referral as part of diabetes care, because it is not being done in many cases. Who needs screening? All diabetics need screening. Type 1 diabetics can be seen after 5 years of occurrence, and type 2 on the diagnosis at the time of diagnosis. Annual screening is at least mandatory, and more frequent examination is required with poor glycemic control patients, pregnancy, and long duration of diabetic patient. Uh, what are the red flags for urgent referral? Patient should be referred immediately if there is a sudden vision loss. Sudden vision loss means there is some activity of proliferative diabetic retinopathy, floaters or black spots, distorted vision, and also non-diabetic retinopathy without follow-up. So what happens if detected early? Vision can be prevented with laser injection and even monitoring. These are the less like invasive techniques, and patients need they don't need complex surgeries if treated early. So what are the challenges? Challenges are patient come late. There is even the limited access for imaging. Patients compliance issues are there, and resource constraints in low income settings. Uh, what can we do in future? We can do AI based risk prediction models application, home based retinal monitoring if possible, then integration of systemic and ocular data can be done, and personalized DR care if we are able to do, then that will be fantastic way. So what are the role of non-ophthalmologist? So very important role of non-ophthalmologist we can say, because it is a real experience of mine that patients show up very late to the ophthalmologist, and they say that they are not being said that you need an ocular examination. So whatever. So the internist and physician can see and refer the patients. In also gynecologist also they have pregnancy. There is a diabetic and they can have a diabetic retinopathy, so they can also refer the patients. And also urologist have got kidney disease patients who have diabetes and diabetic retinopathy. Last slide. And and also MDGPs who can screen in remote areas. Last slide. So take home message will be: check the eye before the patient loses sight. Early referral means vision saved, not just treated, and managing diabetes includes eye screening as mandatory tool. Thank you very much, and thank you for the kind hearing.
Dr. Lily Rajvamshi for very wonderful presentation, very relevant, timeful, and hot cake in the practice as well. So she has actually awakened the society, aware the peoples presented over here. So very thank you from our side. So similarly, we have another very powerful, renowned the keynote is invite over here, Dr. Nisha Acharya. So Dr. Nisha Acharya is an assistant professor in unit in charge of the Department of Conservative Dentistry and Endodontics at the Institute of Medicine, Maharajganj Medical Campus, Tribhuvan University Teaching Hospital. She currently serves as the Vice President of the Conservative Dentistry and Endodontics Association of Nepal and is an executive board member of the Nepal Health Research Council. Ma'am, it's over to you.
Thank you, sir. Thank you very much. Respected chairs, ladies and gentlemen, dear colleagues and all the dignitaries over here, a very good afternoon. In line with Nepal Health Research Council's 12th Summit theme, today I'm presenting my research. It's a molecular research in which we've targeted transgene receptor potential vanilloid 1 by epigenetic modulations and has seen its implications for chronic orofacial pain management. So Sora has already given my introduction. To introduce myself, I am Dr. Nisha Acharya. I'm an assistant professor and a consultant endodontist. And currently, I would like to introduce myself as a PhD student. I am currently pursuing a PhD in psychosomatic pain, and my main focus is on orofacial, chronic orofacial pain conditions and its molecular implications. So to start with my presentations, TRPV1 is, the full form is transgene receptor potential vanilloid 1. It's basically a sensory, it's a pain ion channel or pain signaling receptors, and mainly it is activated by heat, capsaicin, and acidic conditions. So basically it triggers pain signals, and it has a very big role on pain perceptions, inflammation, hyperalgesia, and it can be a great target for pain relieving drugs. So the core, the message or core theme of this research is we're trying to epigenetically suppress TRPV1, and we're trying to activate it and see whether it leads to chronic pain conditions or not. So to see epigenetic reprogramming of TRPV1, TRPV1 is basically low in normal baseline condition. In normal baseline, no disease condition, it is basically suppressed, but it is exaggerated in cases of hyperalgesia or allodynamia, or in persistent, leading to persistent nociceptive sensitizations. So the core, the question is why orofacial pain becomes chronic. When we have pain and then we get a treatment, but it doesn't get resolved, it stays there. So the question is why it is becoming chronic. Why after disease or a treatment, after we treat the disease, why it is not going? And patient comes to us, it's very frustrating, and we call it a psychosomatic pain. You have a psychological problem, you go to a psychologist. Patient will never go there. They actually have pain, but we do not know the mechanism why the patient is having the pain. So even after original injury resolves, the TRPV1, these receptors are upregulated. This is what we wanted to prove from this molecular study. So coming to the problem and statement, I've already said few in my previous slide. So their pain stays there. It's very frustrating for both patient and the doctor, treating doctor. And although it is neuropathic in origin, we do not know how it occurs. Peripheral sensitization is there, TRPV1 receptor is increased, that we know. But what we do not know is how it is overexpressed. What is the disease mechanism? So it's unclear. That's why we wanted to do the study. So the key question is not just what activates the pain, but what keeps the pain system permanently switched on. Why are we, being a pain specialist or a doctor, not being able to treat the patient effectively? Why are we sending the patient to a psychiatrist and telling you you have a psychological problem, you take this medicines, and patient is very frustrated? So this is what we wanted to know. So the rationale of our study is we've targeted epigenetics. Epigenetics is where we're trying to, without changing the DNA sequence, we're trying to see the upregulation of various mRNA or genes. And so basically here we have done DNA methylation and histone modification as an epigenetics, and TRPV1 gene contains CPG rich promoter regions which are potential epigenetic control sites. So epigenetic changes is switch genes on and off without affecting the DNA sequence. This is basically the main theme. So our hypothesis is TRPV1 may be epigenetically suppressed at baseline and activated in chronic pain states. This is the hypothesis we're trying to prove here. So to test this, we've designed an experimental model to directly manipulate epigenetic pathways. If TRPV1 is a pain switch, epigenetic might be that mechanism. It might be the mechanism that keeps that switch permanently on. So if we are able to prove this in our research, then we might have some clinical implications later on. So this is the same thing that I've just explained. In normal state, there is a DNA methylation and histone TRPV1 is off, and when there is epigenetic changes, there is a epigenetic modulation of DNA sequence, and because of that the pain signals will be increased and it leads to the chronic pain state. So the aim of the study is to investigate the role of epigenetic mechanism in regulating TRPV1 expressions and its functional activation in sensory neuron models. These are the objectives. And so we are not only increasing TRPV1 here. We already know TRPV1 is increased in chronic pain conditions. Already the research has shown this. But we're trying to test whether that increased TRPV1 is functionally active and biological relevant or not. So in coming to my experimental design and methodology, this is a very complicated molecular research, so I've tried to compress it in one slide because of various reasons. So we have taken different F11 cells are our research cells, where we've divided it into control group and various other groups where we have added epigenetic drugs like zebularine and VPA, and combination group is also there. And NOR growth factor, we've taken it as a positive control group. So then we have seen TRPV1 expression, and then we've added capsaicin and seen how it stimulates the already stimulated or already upregulated TRPV1 cells. And then we have seen the functional response by immediate early gene activation. And then we check the cell viability as well. So we've checked the cells for 3 and 7 days, and then we've done the capsaicin stimulations, and we've checked for the gene expression, TRPV1 expression, and then immediate early genes like FOS, JUN, EGR1, and ARC. We've checked it after that. And then we've seen the protein level as well, and functional assay was done by adding capsaicin and seen where TRPV1 is further stimulated by adding capsaicin or not, and then cell viability test was also done. So these are the results. In our result, we've seen that epigenetic treatments significantly increase TRPV1 expressions with the in combination group, zebularine plus VPA combination group having the maximum in both 7 days as well as 7 days group plus 30-minute capsaicin added group. In both the group, it was significantly stimulated or upregulated. This is another table where epigenetic modulation and nerve growth factor both upregulated TRPV1, and upon capsaicin stimulation, there was a significant activation of immediate early genes showing that it is functionally active. And where we have added inhibitor factors, when inhibition factors were added, it was inhibited. So there is another result, bar diagram showing the same thing, but when we added the capsazepine, it was significantly decreased, suggesting that the TRPV1 mediated signaling is confirmed. So this is the same thing. We've done the flow cytometry experiment also. It also proved the same thing. Because of time constraint, I'm not explaining it in details. These are our flow cytometry results showing the same thing. This is in nerve growth factor group and control group. So same thing has been approved. And epigenetic modulation upregulates TRPV1 expressions. It is not constitutionally active, but it is epigenetically suppressed under normal condition. And when there is epigenetic modulation, it unlocks the TRPV1 gene expression. And capsaicin alone, if we were add capsaicin alone, it does not increase TRPV1 expressions. It only activates already expressed TRPV1 receptors. And increased TRPV1 is not just present, but it is functionally active also. So we're not just increasing the receptor number, but we are increasing pain signaling capacity also. So this is the whole mechanism which has been shown in a diagram, the same thing summarized. Epigenetic changes and TRPV1 gene activations, then receptor increase and capsaicin response also increase, and finally leading to the peripheral sensitization leading to chronic pain condition, sorry. Conclusion, the same thing described in a pictorial form. And the take-home message is epigenetic transforms TRPV1 from a silent receptor into a driver of chronic pain. And its clinical relevance is now we know how the disease process is occurring, how the peripheral sensitization is happening. So instead of only blocking the pain or instead of only treating the symptoms, we can actually target the epigenetics and do the molecular programming. So these are the same therapeutic implications. We can epigenetic modulators as a novel target for pain management, and we have a potential to develop TRPV1 specific epigenetic therapies. And opportunity for personalized medicine in chronic orofacial pain is there. So we shift from symptom control to disease mechanism targeting. So this is all about my presentations. And I would like to request, when I was going through this research, when I was doing this research, I faced a lot of problem because there was no molecular lab where I could sit and do this research. So when we are forming a policies, so we should also keep in mind for this kind of research where we can sit in lab and do molecular level or gene level research, it will be really helpful. Thank you very much.
Thank you, Dr. Nisha Acharya, for your very brainstorming presentation in chronic care model for chronic pain. And similarly, now we have another invitee speakers, Dr. Lakshmi Prasad Ghimire. So Dr. Lakshmi Prasad Ghimire is a public health professional and gold medalist in Master of Public Health from Northern University, Bangladesh. He was honored with prestigious Chancellor Award by the President of Bangladesh and Nepal, Vidya Bhushan by the President of Nepal for his academic excellence. He holds a Bachelor of Ayurveda Medicine and Surgery from Institute of Medicine, Tribhuvan University, Nepal. So with this brief info, now I would like to request Dr. Lakshmi Prasad Ghimire for his presentation. Now it's over to you, sir.
Thank you, Dr. Puspa, respected chair persons and people present here. My presentation is on about service. Basically, this is a Nagarik Arogya program launched by Department of Ayurveda and Alternative Medicine. This is a public health initiative which is directly communicated with the people. So this study would see the related with the Nagarik Arogya programs related with the NCDS prevention. So this is a program that we reviewed. It's a retrospective study we did for like 1 year data. We reviewed with from the 5 different centers in the urban settings. किन गइरहेको छैन ओके बिचको okay. Yeah, let's see the global burden of NCDs. We can see that now it's very concerning that globally it's NCDs is getting very concerned because it's a leading cause of death in high income countries. It's about 87 now, but projected to be 89 in the by 2030. And whereas in low and middle income countries, it's about 51 and projected to be 72 by 2030 in Southeast Asia. Though in Nepal, it's now currently it's about 66% of the deaths is due to the NCDs, and it is projected like around 78% by 2030. So it's a major concern of the public health aspects, and in most of the cases, the deaths are due to the cardiovascular diseases, cancer, and COPD, and related with the other. So there are the risks: air pollution, major like physical inactivity in the urban settings or urban area, tobacco use, alcohol use. These are the major risk factors for this. And we can see here like also it's interesting with the diet. From the diet perspective, like people are not taking enough fruits and the servings for them, and there are other like hypertension. These are the major causes, and alcohol consumption, obesity, and physical inactivity. So for this, actually, if we see like 5x5 model, this is presented in the multi-sectoral plan for prevention and control of NCDs. There are the different risk factors which are directly related with the non-communicable diseases, and here we can see like tobacco and lifestyles, basically with diets and physical activeness, alcohol use, and air pollution. So these are the major causes, and most of these are the risk factors for the top most non-communicable diseases. Here we see like actually I this presented here because the obesity now it's getting more increase in number, higher percentage. Same way the low food, fruits and vegetable intake, mostly related with the diet. So these are the major risk factors for the NCDs. And Nagarik Arogya program, this is a government initiated program directly communicated with the people, and this is actually developed by the Department of Alternative Medicine, Ayurveda and Alternative Medicine, and endorsed by the Ministry of Health and Population. So this is already implemented in the communities, and now the past government has also declared that the program would be in all the local governments, the 753 palikas, it will be run. So this is basically it focuses on prevention and the promoting of the health and well-being. And here, Mero Swasthya Mera Zimmewari, this is a highly popularized program related with this, and it's a focus on NCD prevention and health promotion. So, and major objective of this is, as I said before, promote healthy behaviors. Actually, this is like how we do, how it is being done. I will show in the next slides. And reduce risk factors of NCDs, increase health awareness, and most important part is the encourage community participation. Basically, the other Ayurvedic services are clinic based, not related with the, I mean directly communicating with the people, but this one is highly potential for that. And major activities are like health educations, conducted in the communities: yoga, meditation, and physical activity, lifestyle counseling, community awareness campaigns. So these are the major activities that's run by this program. And okay. Okay. And for this to run this program, there is a guidelines for like booklet is developed, Nagarik Arogya Karyakram, where it includes all these activities. So this is mainly focused on to increase their physical activity of the people. Yoga, it's a different sessions is done with the school and community people, women groups. So and it's also talk about the different like habits. And here are some activities. We can see the major programs or activities run by the Nagarik Arogya program. And 1/3 of the program is a clinic based, but the others 2/3 are focused on the community and mainly for the promotion of the health and the well-being. So we can see here the different groups. They are doing the program like community awareness, yoga, and lifestyle modification sessions through the different yoga. We know that yoga, different and multiple studies has been done related with the yoga in NCD control and the prevention. It has a high influence in the physical health promotion and the mental health. Also yoga and meditation. This is a very useful one. And from yoga, it's we see like physical activity can be increased. It has a influence on blood pressure, can be lower the blood pressures, blood glucose level, stress and anxiety, sleep quality improved, and other. So the same way lifestyles has also significant support in the NCD prevention related with the well-being of the health. And here in case of through the Nagarik Arogya program, they are delivering the message of through the different programs like it's not doing back. Okay, anyway, so like dinacharya, I mean daily regimen, how it should be, it talks about this, and also about the seasonal regimens like ritucharya, we say dinacharya, ritucharya. From this, how we can be healthy and what should we do, everything is mentioned here. Not working. And also these are all about the healthy lifestyles. So this objective of this is to explore the Nagarik Arogya program initiatives in controlling NCD risk factors among adult population in Nepal. So studies, no, okay. Anyway, as let me go to back, it's not working properly. So here actually from the 5 centers we reviewed the data, and then with the samples of 426 we did the interview, a survey related with this, and 4 basically yoga, lifestyle education, and NCD prevention program, and then yes, this it's not working actually. Okay, yoga, healthy lifestyle, kitchen as a ausadalaya. This one the project implemented, and NCD prevention education. So these are the major focus on this study, and and we found like most of the respondents are the female because the participants were also female in these cases, and age of about like 40 to 60 age group are the higher in a percentage. Results I would like to explain through this table. Here, like among the respondents, 243, they said like their physical activities is increased, and 102, they said like their dietary practices were improved. through the, and also reduced alcohol use and tobacco use were 90 and 81. It's about 57% of, they said like it's increased physical activity, 24% dietary practices with improved kitchen, and 21% reduced tobacco use and 19 alcohol use. And moreover, like 60% of them were involved in the yoga sessions. Oh. Here we are. Yeah. So findings here, you see like Nagarik Arogya program, it promotes physical activity, encourages healthy diet and behavior, reduces tobacco and alcohol use, which are the major risk factors of the non-communicable diseases. And what I would like to conclude from this study is that this is very effective preventive initiative, Nagarik Arogya program, which is directly benefited with the people, and strong potential for NCD control. So this community empowerment is the key of this program. And next is the continued optimization of follow-up, of tracking, and expansion of structured behavior change interventions for further strengthened program impact is important. So this program is very, I would like to say like this program is very effective for NCD control, but this would be like integrated with other health program as well. And this is very important for the multiple, multi-dimensional program to be included in the non-communicable diseases run by the country health system. And I would like to acknowledge 5 Nagarik Arogya centers from Kathmandu, Tarkeswar, Budanilkantha, and Tarkeswar, Budanilkantha, Sankarapur, and from Lumbini. So these centers, I would like to thank for them and the respondents who are involved in this study, and Dr. Pushparaj Paudel for his support. Thank you.
Thank you, Dakshav. Despite of some technical challenges and constraints, Dakshav made an effort to visualize the Nagarik Arogya program in the context of non-communicable disease control and prevention. Thank you very much, Dr. Lakshmi Prasad Ghimire, and we may request him to carry out such novel initiatives and reviewed the programmatic provisions made in the health systems. So with that note, now we have another presenters of the session, Devraj Pokhrel. So Mr. Devraj Pokhrel has an academic background of biotechnology and microbiology. He is currently working as a research assistant at Nexus Institute of Research and Innovation under supervision of Dr. Santosh Dulal. His works involves research activities in microbiology and biotechnology. It's over to you, Mr. Devraj.
Good afternoon, everybody. Title page. Good afternoon, everybody. I will be presenting our study on burden of mycosis and emerging antifungal drug resistance in Nepal across One Health interface. This study was conducted at Nexus Institute of Research and Innovation under the supervision of Dr. Santosh Dulal. I will be walking you through background, research objective, methodology, result, conclusion, and take-home message. Talking about AMR, it is a global public health threat. AMR is a global public health threat which occurs when microbial stop responding to antimicrobial drugs, and it is a threat to global One Health interface when such resistance organism transfer from one sector to another and vice versa, which complicates treatment. In Nepal, there were over 6,400 deaths attributed to AMR and over 23,000 deaths associated with AMR. An estimated of 1.87% of Nepalese population suffer from fungal disease annually. Despite this, fungal disease remain under study, with most research focusing on treatment and pathogen identification over resistance pattern. And fungal infection are very crucial in food safety, mycotoxin contamination, and immunocompromised population. Talking about our research objective, our main research objective is to assess the prevalence of resistance trend in fungal pathogen from One Health perspective, and to access the and to identify etiological agent and prevalence of mycosis, and purpose actionable recommendation for antifungal drug resistance. Talking about methodology, we initially searched literature from databases like PubMed, Google Scholar, and Web of Science, identifying 288 literature between January of 2000 to December of 2024. After applying inclusion and exclusion criteria, we identify 109 studies. Our inclusion criteria includes study focused on Nepal, primary studies, and study from One Health interface. After that, we screen the data, and based on the data, we abstracted the relevant points and findings to present thematic area, identify gaps and implication. From our findings, we identified Candida and Aspergillus are the main pathogen in human, whereas superficial mycosis and mucormycosis are most prevalent mycosis in human. Talking about the resistance pattern, only 19 studies showed resistance among 3 pathogens, among which Candida albicans show higher resistance among first gen azole. Similar pattern was seen in non-albicans Candida. Although few data were present with dermatophytes, it also showed higher resistance with first gen azole like fluconazole and ketoconazole, and no data on genetic variants were given. From the methodology used to diagnosis of fungal pathogen, only 4 papers used molecular techniques like MALDI-TOF and DNA sequencing, while rest relied on conventional techniques like staining and microscopy and culture method. In terms of co-infection, Aspergillus and Fusarium species were most prevalent. From the 8 studies from animals, Penicillium and Aspergillus were the most prominent, and mycotoxicosis is the most common condition. In terms of agriculture, only 5 studies were found. From there, Cladosporium and Alternaria were the most prevalent pathogens, while rot, spot, and rust were common mycosis in agriculture. Both animal and agriculture sector use conventional techniques like staining and microscopy for pathogen identification. In terms of One Health interface, Penicillium and Aspergillus were commonly found, while no pathogen were common among human and animal, and rest of the pathogen like Cluveria and Fusarium were common with human and agriculture. From our study, we proposed the following recommendation: strengthening multi-sectoral collaboration under One Health framework, creating a national antifungal resistance databases, and utilizing COVID-era infrastructure for advancing molecular diagnostics, and preventing over-the-counter dispensing of steroid and antifungal drugs, strengthening our surveillance system of antifungal drug resistance even from the local level, and integrating fungal disease into livestock and crop insurance schemes. To conclude, Aspergillus fusarium and Candida species were the most prevalent among all sectors, while superficial mycosis and mucormycosis were common in human, whereas mycotoxicosis is common in agriculture, in animal, while rot and spot are prevalent in agriculture. The key take-home messages are, while the policy exists, their effective implementation remain weak. Local awareness and research prioritization should be implemented. Cross-border contamination should be addressed, and antimicrobial waste management should be prioritized. With this, I would like to acknowledge Nexus Institute of Research, and thank you.
Thank you very much, Devraj Pokrel, for bringing the very urgent public health concern, not in the Nepal, in the entire globe. So responding such a public health threat with one health approach is utmost need. So now I would like to invite Dr. Bishnu Dayal Patel. So Dr. Bishnu Dayal Patel is the head of the Department of Dravyaguna, Metria, Medica and Pharmacology at Ayurveda Campus and Teaching Hospital, Institute of Medicine, Trivandrum University, Kirtipur. He serves as an assistant professor and is actively involved in academic leadership, teaching and the advancement of Ayurvedic medicine. So now the podium is over to you, Dr. Patel.
Thank you, respected chairs, academician, researcher, and presenter here over. I am Dr. Bishnu Dayal Prasad Patel. On behalf of Nepal Health Research Council, I'm going to talk on overview on National Guideline for Ayurveda and Traditional Medicine Research in Nepal 2026. This is talking about the content of these guidelines. It contains 6 sections. First section, background and scope. Second section, integrative research approaches. Third section, drug standardization. Fourth section, safety and toxicology, toxicity evaluation. Fifth section, clinical evaluation. And sixth, research in folkloric and ethnomedicine. Talking about the background and the scope of designing formulation of these guidelines, we go back our culture about the use of traditional medicine like the Ayurveda and Shoripa and so on and so on. So 80% WHO report shows that 80% the population use this medicine in our countries and Asian countries, developing countries. On this background, also we have complex the principle of the traditional medicine like the Ayurveda, and also the formulation is very complex. So how we can conduct sound or the evidence-based research in this system, traditional system. And we have also the research center like the Nepal Health Research Council and National Ayurveda Research and Training Centers. So this is the urgent of the day to develop a comprehensive guideline, and also the WHO strategic traditional medicine strategy 2025 and 2034 has been published, and this guideline is also adheres to that guidelines. So this is the need of the guidelines. And when we talk about the this importance of this guideline, standardization, safety, efficacy, and quality control is main issue of our researches and evidences we are generating nowadays. So we are missing our concept also, like the Prakirti dosas is very important to talk about the personalized medicine or the whole system research. So nowadays is urgent to how we can address the whole system research. So this guideline focus on the whole system research and bridging the modern knowledge, modern guidelines of the research with our traditional principles and practice beliefs and like the faiths. So These are all about the things, and the scope of this guideline is to develop the research protocols. It guides us to develop research protocols. It ensures the quality, safety, efficacy of the research, and also to bridge the traditional knowledge with the modern research methodology, and also collaboration and capacity development of our researchers in the traditional medicine and the modern science or conventional science. Then also it's very important to talk about the evaluation of safety, efficacy, and quality control, and also it helps to generate evidences to formulate the policy, national policy. These all are the major scope of these guidelines. So talking about the integrative research approaches, bridging the traditional knowledge with the modern sciences, we follow multidisciplinary, interdisciplinary, and transdisciplinary guidelines addressed in this guidelines. So also we try to solve the holistic solution for the complexity of Ayurveda and the traditional medicine, the disease pattern and the treatment pattern or the prescription pattern in Ayurvedas and the traditional medicine. These are the flow chart of how we can integrate with the traditional researcher with the conventional science or the applied sciences. These are the sciences we can work together to generate the evidences, sound evidences. This is the very, very important nowadays, how we can the whole system research, this guideline address this in coherence with the WHO traditional medicine strategy 2025 and 2034. How we can develop a protocol to conduct the whole system research in Ayurveda and traditional medicine or personalized medicines. So these are the follow. We can integrate both because in traditional medicine, we can say the Ayurveda, there is a pattern of disease, not a disease only. Because we talk about the diabetics, it is the we have a 20 types of perme that's maybe correlated with the diabetes but not diabetes. So how we can conduct, if we correlate with diabetic one of the perme, that is the batik perme, with the diabetic, then we also analyze the Prakirti, and then we select we can tag the Prakirti, one of the Prakirti or all the 7 type of Prakirti as an inclusion of the participant, or you can say the participant or the disease patient, we can say the patient. So with the integration, combination with the symptoms and the other symptoms and the diagnostic tools, this can be done to analyze the and can be used to generate the evidences. And the second, third one is talk about the evaluation of the standardization. These are the standardization, all about the WHO guidelines, quality control guidelines, and we follow these guidelines to होइन तपाईले यो ब्याकमा यो म फरवर्ड गर्छु, तपाईँ ब्याक हुन्छ यो त ओके ओके तपाईँ छोड्नु. These are the WHO guideline for the standardization. We follow, this is the safety guideline. We conduct the acute toxicity, subchronic toxicity, and long-term toxicity, local toxicity too. And these are the also specification of the procedure and the drug specification, minerals, herbs, and animal byproduct. We apply this clinical evaluation for the Prakriti, Dosh, and Dhatu, Agni, in integrated way and can develop the evidences. This is the follow-up chart for the raw material. We can first of all differentiate in the proven or unproven, known and unknown. Then if the drug is proven, then we directly conduct the, after the standardization, we directly conduct the clinical trial from the phase 2. If a drug is unproven, then we go through the all the toxicity, safety, and the standardization, then the clinical trial way. And these are all the follow chart. Intervention, we have two types of intervention, like the therapeutics and the therapy based and the drug based intervention. So all the detailed guidelines is provided in the this national guidelines, traditional guidelines, and the probably known materials. We also conduct this pathway to follow the to generate the evidences. Forward, 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 forward. Okay. Then these are the ninth step to conduct the clinical trials, and you can file your patency whenever the novelty will be generated. And this is very important also for the traditional medicine and Ayurveda, research pharmacology. This is the there is a blue, green pathway that this is a very important that the we are claiming that our medicine are effective, but in the modern tool or the conventional tool, it may be it may not be the finding the evidences of the good efficacy. So we can go back to the lab. The process of drug development is from the lab to the clinics, but in traditional medicine or practicing thousands of years before, in such a medicine, we can go back from the clinics to the lab. This is the reverse pharmacology, and we can generate the evidences as the pathway shows. And this is it is also very important that some peoples in our community society claiming that we have a cancer treatment, we have a kidney failure treatments. Such a person who have developed a folkloric and the ethnomedicinal guidelines. In this, we can first of all make a trust building with the traditional healers, that traditional practitioners with the academician or researcher, conventional researcher, and observe the evidences independently. After that, if the evidences is okay, then the in the short number of patients, we also observe the clinical efficacy of the drugs. Then after, we can validate the medicines with the process of bridging the bilateral, trilateral agreement with the traditional knowledge holder and the researcher or the institution, and we follow for the generation of evidences by conducting the clinical trial. These all are mentioned in this section. Okay, and we have to consider, sorry, and all in the summary, I like to recommend here, these guidelines can provide us the evidences of the traditional healing practices or the traditional medicines to the conventional nowadays this era, and the safety can ensure safety, scientific validation, robust scientific evidences, or most of the thing is the global acceptances. Because of the robust guideline, standard guideline, we cannot generate robust evidences and cannot claim to the global benchmark. So this is very important to develop the evidences from our faith, belief, and practices of traditional medicine in Nepal and all over the world. Thank you.
Thank you, Dr. Patel, for highlighting the overview of traditional medicine guidelines draft supposed to be endorsed by Nepal Health Research Council very soon. So we know that the traditional medicines need to boost up by science and translating its essence of nectar with the policy and into the action. So thank you once again, Dr. Patel, for highlighting the guideline. So similarly, now we would like to invite another invite speaker, Dr. Nirmal Bhushal. Dr. Nirmal Bhushal is an assistant professor at the Ayurveda campus, Tribhuvan University, Kirtipur, Kathmandu. He is specialized in Ayurvedic Panchakarma and holds advanced qualification in the field with a PhD in Ayurvedic Panchakarma. Dr. Bhushal is actively engaged in teaching, research, and the promotion of traditional Ayurvedic practices. It's over to you, Dr. Bhushal.
Sri Gurubhyo Namah. Thank you, respected chair, delegates, and all the respected and present here. Myself, Dr. Nirmal Bhushal. For the next 10 minutes, I will be presenting how strengthening Ayurveda research can help in informed implementation and how it can help in strengthening the system. So, to move ahead, I am very much thankful to the previous speaker. He has presented the scenario of Ayurveda. So, to look what Ayurveda is, we all know it is the land of Ayurveda. We are from the land of Ayurveda. Himavate Dachide Parshve. The first scientific conference, like just the today's conference, the first conference was organized at the lap of the Himalayas on the south of the Himalayas. This is the textual reference in Charak Samhita. And we are very unfortunate and we cannot say the exact date. But the researchers from Western world claim that Charak Samhita is a 5,000 years old textbook. And the same thing is in our constitution. Ayurveda has a big place. Our policies have given a big space for Ayurveda. And there is a global increasing demand because we know that WHO traditional medicine strategy has also focused the need for this sector. And I am very much thankful for different researchers from different academic institutions in Nepal and abroad who have found that Nepal is very much rich in medicinal plant, and they have documented different number of articles. And in this sector, in herbal medicine, we know in biodiversity we are very rich. But the current scenario of actual on the core principles of Ayurveda, if we look at the principle-based Ayurveda researches, they are very much limited to National Ayurveda Research and Training Center, Department of Ayurveda and Alternative Medicine, and few academic theses on MD or undergraduate scholars. And there are certain standardization studies, a few standardization studies, and certain studies like we can see the effectiveness studies of Ayurveda program, and certain studies are limited to the efficacy of particular drugs. There are very much limited sets of publications. We have very much limited publications from Ayurveda communities, international journals. The journals that are in our communities are also focused to particularly like the NABJOL indexing and that level. We don't have that sets of Q1 journal publications or PubMed sets publications. The scenario is, although there are researchers from academic institutions like from Kathmandu University, Tribhuvan University, Department of Botany, Chemistry, Natural Plant Chemistry, they have done good quantity of research works and published in Q1 journal. But particularly from core principles of Ayurveda, looking at the dosa, prakriti, and on the basis of the principles of Ayurveda, what Ayurveda says is Karyakarad Vabasi Darvyanam Good Karmado Parichya Sthapanam Samyak Anusandhan Uchyate. How research can be done? That core principles are lacking in those research, but we are thankful something is better in that sector. The next thing is myself, I have been involved in few research activities, and in a small scale, what I have shown is from the small research grants from the universities. I found a very important finding from a study like hemodynamic and hematological changes induced by Panchakarma, that Sarvanga Swedan. Sarvanga Swedan is a basic health service. So it is an essential health right of an individual, and the safety of this procedure is very important. We have launched this program all over the nation, but to establish the safety. So I found that the procedure was safe. The 7 days intervention was there, and the next study, one of the study we did on the relevancy and sustainability of Ayurveda education and Ayurveda programs from the Department of Ayurveda and Alternative Medicine in collaboration with the research center. And in that study we found to sustain those studies there was lack of funds, and inadequate physical infrastructures and human resource gap was found. Similarly, if we look at the satisfaction study of the service recipients from participants, the participants said that the Ayurveda services are effective, but the range of availability is lacking. And in one very interesting study, we tried to visualize the geospatial location of the Ayurveda centers in Kathmandu Valley, and we found that the distribution was not appropriate. Like in peri-urban areas, there was lack of even Ayurveda centers within the valley. So this type of study can be generalized for the nationwide to find the validity and the visualization of the all centers. And in the age of AI and availability, why we cannot visualize all our centers and bring the health system in that area, but this needs this cannot be performed by an individual researcher. The organizations, there are a number of organizations for Ayurveda, Department of Ayurveda Alternative Medicine, Singadhara Vaidyakhana Vikas Samiti, Ayurveda Medical Council, Research Center, Ayurveda Hospitals, Department, all over the nation, Ayurveda centers, 2 universities running Ayurveda courses, and one particular university that is established for the Ayurveda development, for research, academic activities, and even for drug production. The act is very good, but the implementation is very weak. Even I am a Senate member, but we haven't started doing research before organizing the curriculum. We have haphazardly started the curriculum activities, started yoga and meditation course without taking the permission from the Medical Education Commission. So we are not doing researches and starting the course. What is the need of the curriculum? What type of product we should develop? That is not being done. This is we see the unfortunate thing. How we can breeze the science of the traditional knowledge, the documented science of our own heritage to the global current scenario. It should be a very important step, but there are few key challenges. There is a lack of dedicated funds and lack of documentation. This is because we lack the trained human resource, and there is a lack of interdisciplinary collaborations within the nation and the international community. The classical Charak Samhita is very fortunate. We are very thankful for the acharyas who did the research at that time, and they have the documented ways of doing research. There are tools for research. The first peer review concept we can see in the Ayurveda, the peer review concept of Bad, how the thing was to be put in the scientific community, how the other reviewers would take, and this concept is just like today's scientific concept. So if we don't take on our things, and how others will say that the heritage, so it is a very important step. And there are gaps in the evidence generation because of the limited clinical trials of today's scenario. Although that was a documented science, but we lack it, and there is a limited publications, which is the most important area. But there are opportunities. So opportunities in the case of non-communicable disease, Ayurveda can be a good options, like the previous speaker, Nagrik Arogya Karyakram, Citizen Wellbeing Program, which is a very good, like for example, it was a very good initiative since 2018. We were doing that activity, and we got a lot of good response in the and there are other scopes, like we have a national wellness strategy coming on, and I myself have been working as the advisor for that on the sector of Ayurveda, and I am fortunate if we have and if we bring real researchers from other interdisciplinary sectors and work together, then it would be fruitful. The other thing is, if we look at the aspects of please. Okay, if we look at the aspects of the opportunities, the collaboration between the institutions, academic and the research institutions, and not only strengthening Ayurveda sectors, strengthening out of the box, like the different universities, there should be one fund from where the dedicated fund from where Ayurveda researchers can apply. Now there are different funds in the name of Ayurveda from different institutions. So the real researchers from the interdisciplinary sectors or multidisciplinary sectors are not clear where to apply and with whom to work together. Like the Ayurveda campus is there, or Department of Ayurveda is there, or which particular institution we are going to collaborate and work together. There is a big gap in our sector. So it would be better if we have a dedicated fund one fund system, one fund channel and dedicated for Ayurveda, and the human resource training to be targeted for biostatistics and research methodology for Ayurveda academics to work for today's standards, and publication supports which would bring this science on the global platform. And it is an opportunity for Nepal, that Nepal can give something to the world, that is Ayurveda. If we are there, we can give something, it is Ayurveda. If we can validate one particular statement that is in Ayurveda, we can do a big research in this science. What I feel personally, and what the co-friends or those friends who are working with Ayurveda sectors, they believe on us. So I am very much thankful for the NHRC for providing the opportunity. I thank all of you for listening, and I am very much thankful, and I am very unfortunate because of some of the technical issues, couldn't show the few next slides. If it is possible, I would have just a glimpse to conclude. Thank you so much. If any questions in between, I would invite the questions. Okay. Okay, institutional strengthening, as I said earlier, it is very important, not only within the nation, and there should be strengthening, and the university and hospital collaboration, which is very important. Not only establishing a university with act is not sufficient, and the incentives for research publications I told, and there are the best and most important is we do research and small activities, but they are not implemented to the policies, health policies. They are not going to the community level, which is very important. Like I did a study on the hemodynamic effect of Swedana. If this study could be done at a large scale, nationwide, with multiple sectorial researchers and academicians, then it would be a game changer. Like the saunas, the health clubs, all are providing the sauna facilities, and no one is certain the adverse effects. No one is certain the health benefits. We could give a good thing to the society. So the research should be collaborated, multi-sectorial approach, and funded. So that is the thing I want to request you, all of you, to sensitize. So, and the one thing is, we can develop Nepal as a sector for Ayurveda based research hub, and it is opportunity because we are from the land of Ayurveda, Dhimavate Dachide Parshve. Thank you so much. Namaste.
Thank you, Dr. Bushal, for raising a serious concern about research policies, programs in a place, and the government's urgent actions in this regard. And we, on behalf of Chair, are very sorry for technical insufficiency, Dr. Bushal. So now we have a very renowned invitee speaker, Dr. J.N. Pandey, Himali, sir. Dr. J.N. Pandey is a senior consultant physician specializing in general and internal medicine with particular expertise in rheumatology. So now I would like to request Dr. Pandey for his presentation.
नमस्ते सबैलाई। म त प्रज्ञा प्रतिष्ठानको चाहिँ चिकित्सा साहित्यकारको हिसाबले म के भन्छु भनेदेखि यी सबै कुराहरू नेपालीमा उल्टा हुनुपर्छ भन्छु। त्यसो भएको हुनाले अलिकति कठिन शब्दहरू बाहेक अरू म सबै चाहिँ नेपालीमा बोल्ने चाहिँ प्रयास गर्छु। इफेक्ट अफ इम्युनिटी, यहाँ अलिकति चाहिँ नि अब फरक टपिक्स आएछ। मैले त यो रेमाटिक हार्ट डिजिजको बारेमा राखेँ त, यो मेरो इनोभेसन हो। मैले यहाँ तपाईहरुलाई इनोभेसनको बारेमा कुरा गर्दैछु। म इनोभेटर हो, तर जुन परिचय दिनुभयो त्यति सफिसिएन्ट त छैन। मैले पनि मागिनँ मेरो परिचय भन्यो भने चाहिँ लास्टमा हु इज हुमा चाहिँ मेरो चाहिँ परिचय लेखिया छ। साहित्य परिचय कोषमा पनि लेखिया छ, लास्टमा पनि। यो चाहिँ अलिकति भएन, किनभने यो एकाडेमिकल फर्म भनेको यस्तो चिज हो जहाँ डिसिप्लिन चाहिन्छ। अलिकति कुरा गरेर कपी गरेर बरबराउन त जसले पनि सक्छ। सबभन्दा पहिले त म के भन्छु भने इन्टरनेसनल, मेरो त 8 मिनट त गइसक्यो है, उहाँ खोज्दै हुनुहुन्छ है फेरि। खोज्दै हुनुहुन्छ उहाँ मेरो टपिक मिलेन इन्टरनेसनल चाहिँ नि एउटा रिकग्नाइज चाहिँ समय के हो भने 15 मिनट हो है 10 मिनट होइन यो 10 मिनट राख्दाखेरि के हुन्छ भने हामीहरूको जुन मेन्टालिटी कन्स्ट्यान्ट हुन्छ साइकोलोजिकल इफेक्ट पर्छ हामीले एक्सप्रेसन गर्न सक्दैनौँ जुन चाहिन्छ किनकि हामीले टाइमतिर चाहिँ माइन्ड गइरहेका हुन्छ त्यसो भएर इन्टरनेसनली एक्सेप्टेड टाइम भनेको 15 मिनट हो यो पनि हामीले अलिकति गल्ती गर्दैछौँ कि जस्तो मलाई लागिरहेको छ र हो यो इन्ट्रोडक्सन मैले जति पनि काम गरेँ जुनसुकै हस्पिटलमा काम गरेँ यसको बारेमा भन्दाखेरि पनि यहाँ त तपाईँहरूले पढ्नुहोस् म त सोभियत सङ्घमा पढेर आएको हाम्रो यो कपी गर्ने चलन छैन दुनियाँमा केटाकेटीले पढाउने जस्तो चाहिँ एआईबाट चाहिँ सबै कपी गरेर ल्याएर देखाउने चलन पनि छैन जो अहिले यहाँ भइरहेको छ हाम्रो त भिजुअलाइज हो भन्दा पनि अडियोलाइज हो अडियोलाइज मेथड अफ एक्सप्रेसन अफ द इनोभेसन्स है यो तपाईँले पढ्न सकिहाल्नुहुन्छ यो के हो भनेदेखि म प्रसुति गृहमा काम गर्दाखेरि के फेला पारे अलि यो तपाईँहरू पढ्दै जानुहोस् माथि जाँदै जान्छ मेरो आफ्नो कुरा राख्दै जान्छु प्रसुति गृहमा के गर्यो भने बच्चा मरेका आइएमबीहरूको चाहिँ नि ब्रेस्ट इन्गर्जमेन्ट हुँदाखेरि त्यो दुधलाई कसरी सुकाउने भन्ने कुरा थाहा रहन्छ त्यहाँ म त चाहिँ नि एमडी मात्रै गरेर आएको थिएँ रसियन प्रडक्ट भनेपछि त हामीलाई त देख्नै नसक्ने मलाई चाहिँ पोस्ट अपरेटिभमा चाहिँ यो पनि हेर्दै जानु यसलाई अलि उ गर्दै जानुहोस् है भाइ भाइ माथि मिलाउँदै जानुहोस् यहाँ हेर्दै जानुहुन्छ उहाँहरू म यो आफ्नो कुराहरू राख्छु के पनि साइन्स हो अनि मैले के सोचेँ भने म त्यतिखेर एमडी थिएँ पोस्ट अपरेटिभ वार्डको इन्चार्ज थिएँ म रेसिडेन्ट अनि मैले सोचेँ ओहो हामीहरू के ल्याउनु त आट्रोपिन मात्रै होइन आट्रोपिनले त सबै चाहिँ अङ्गको चाहिँ सेक्रेटरी फङ्सन त डिस्टर्ब गर्छ ब्रेस्टलाई मात्रै कसरी गर्ने त भन्दाखेरि मैले त्यहाँ एउटा टेक्निक डेभलप गरेँ जुन टेक्निक अहिले पनि प्रयोग भइरहेको छ त्यहाँबाट कान्तिमा गएँ सोरुवाबाट यो कान्तिमा जाँदाखेरि मैले रिमाटिक हार्ट डिजिज भनेर पत्ता लगाएको नेपालमा पहिलो इन्फेक्टिभ किनभने रिमाटिक खोरिया भन्दो रहेछ त्यहाँ अनि अर्थराइटिस भन्दो रहेछ सानो सानो बच्चाहरू बिचरा 10-12 वर्षको बच्चादेखि चाहिँ त्यो सिम्टम सुरु हुने अनि डक्टरहरूले हाँस्दै यो खोरिया हो म त त्यतिखेर पिएचडी गरेर आइसकेको थिएँ अनि मलाई साह्रै मनमा लागेर यो मैले एक्स्ट्रा कुरा गर्दैछु यो हेर्दै जानु होला है फेरि यो भाइ यो ऊ गर्दै जानु मैले आफ्नो कुराहरू राख्दैछु है त्यसपछि चाहिँ मलाई के लाग्यो भने मलाई अचम्म लाग्यो डक्टरहरूले यत्रो बच्चाहरूलाई कसरी चाहिँ यसरी खेलाउन गरिरहेको छ अनि मैले रसियन लिटरेचर चाहिँ डिटेलली पढिसकेपछि मैले यो चाहिँ नि टपिक्समा मेथोडोलोजी यो प्रयोग गरेँ तपाईँहरूले हेरिहाल्नुहोस् यहाँ यो त पढ्न सक्नुहुन्छ तपाईँहरूले मैले यो कुनै कपी गरे होइन एआईबाट कनै झिकाए होइन यो बढाउँदै जानु है भाइ त्यसले गर्दाखेरि मैले के डेभलप गरेँ भनेदेखि चाहिँ नि मेरो क्लिनिक त्यतिखेर चाहिँ पुतली सडकमा थियो त्यो बच्चाहरूको सबभन्दा अब यहाँनिर म तपाईँहरूलाई फोकस गर्छु बच्चा पाइसकेपछि आइमीहरूले के गर्दो रहेछ आमाहरूले भने निद्रा त थकाइ त सबैले लाग्छ बच्चा एकातिर सुत्ने कम्मल ओढाएर सुत्यो हाम्रो माथि हिमालदेखिको तराईसम्म सुत्यो आमालाई यता सुतिरहेको छ बच्चाले खुट्टाले उता कपडा फाल्छ रातभरि नाङ्गो हुँदो रहेछ बच्चा यो इभिडेन्स हो यो त्यसपछि के हुँदो रहेछ त भने बच्चालाई चाहिँ कोल्ड फिलिङ भयो हुँदै हुँदै जाँदै इम्युनिटी डिक्रिज भयो बच्चालाई बिचरा त्यो भर्खरको बच्चालाई अनि कोल्ड उसले गर्दाखेरि त्यसले गर्दाखेरि के हुन्छ रहेछ भने 3 वर्षको उमेरसम्म पुग्दाखेरि त्यस्तो हुँदाखेरि के हुँदो रहेछ त भन्दाखेरि इम्युन चाहिँ नि उसको डिक्रिजमेन्ट हुँदो रहेछ त्यसले गर्दा स्ट्रेप्टोकोकल इन्फेक्सन चाहिँ उसलाई चाहिँ लाग्दो रहेछ र 3 वर्षदेखि 5 वर्षसम्म त आमाहरूलाई थाहा हुँदैन अलिअलि रुवा लाग्यो खोकी लाग्यो टन्सिल बढ्यो अलि इत्यादि मात्रैको कुराहरू भयो अनि पछि गएर त भने 7 वर्षदेखि अलिकति चाहिँ नि सिम्टम देखा पर्दो रहेछ 9 वर्षमा पुरै सिम्टम देखा पर्दैछ विकट त त्यही हो हामीले एमडी हुँदा मैले चाहिँ रेजिस्ट्रेसन दिँदा 405 हो भनेपछि डक्टर कति थियो होला त 1000 पनि डक्टर थिएनन् आधा त बाहिरै थिए अनि देशमा कसरी चाहिँ डक्टरहरू हुने त्यसले गर्दाखेरि ट्रिटमेन्ट पाउँदो रहेछ बल्ल बल्ल लिएर आयो काठमाडौँ कान्ति हस्पिटल है सबैभन्दा कान्ति हस्पिटलमा लिएर आयो खोरिया रिमान्ड भनेर डक्टरहरू चाहिँ हेर्ने अनि मलाई त साह्रै चित्त दुखेर मेरो क्लिनिक रोमा एडभान्स पोलिक्लिनिकमा थियो त्यहाँ मैले एउटा बिरामीले मलाई स्टिमुलेसन दिएको छ कहाँबाट भन्दै थिएँ तपाईँको मेरो आफ्नो हिस्ट्री यसैको इनोभेसनको हिस्ट्रीमा भन्छु 15 मिनट त मैले लिने है 15 मिनट मैले यो मान्दिनँ यो तपाईँहरूको म साइन्टिस्ट भएको हुनाले साइन्टिफिक किसिमले म जान्छु त्यसैले गर्दाखेरि एउटा बच्चा चाहिँ नि रेटिनल चाहिँ नि तपाईँको चाहिँ नि रेटिनोपाथी भएर आएछ, सानो 15 वर्षको बच्चा। पढ्दै जान्छु डाक्टर साहब, गोर्खादेखि लिएर आएको, मेरो नाम त्यहाँसम्म पुगेछ कि गोर्खादेखि लिएर पढ्दै जान्छु, पढ्न सक्दिनँ भन्यो। यो त चाहिँ रेटिनल मसलको चाहिँ आइरिस मसलको कुरो हो, यो त कन्ट्राक्टेबिलिटी चाहिँ एकदम चाहिँ ऊ भइराखेको छ। अनि मैले कान्तिमा पनि काम गरिराखेको त्यतिखेर मैले चाहिँ बाथको चाहिँ ट्रिटमेन्ट उ गरेँ सिरियसली। अनि तपाईँले भन्दै जान्छु कि म चाहिँ नि इन्टरनेसनल आरएसटी इन्टरनेसनलको एसियाको साइन्टिस्ट हो यसको तर्फबाट है, यहाँको चाहिँ यो रिप्रेजेन्टेटिभ हो म चाहिँ। त्यसपछि चाहिँ नि यो के भयो त भनेर टेस्ट गर्दाखेरि त ठ्याक्कै त्यो रिपोर्टै पोजिटिभ आयो। अनि मैले ट्रिटमेन्ट दिएको त राम्रो भएको थियो। त्यसैबाट चाहिँ नि यो म भएर यो मेरो पर्सनल, यो कहीँबाट नक्कल गरे होइन, यो मेरो पर्सनल चाहिँ इनोभेटिभ चाहिँ नि कुरा हो। यही यो चाहिँ रिभ्यू है, फेरि तपाईँहरूलाई यो इनोभेसन हो, रिभ्यू हो, यो इन्टरनेसनल लेभलमा चाहिँ नि यो गइरहेको छ र डब्लुएचओले यसको रेफरेन्समा चाहिँ प्रयोग गरिरहेको छ इन्टरनेसनल लेभलमा है। त्यसले गर्दाखेरि त्यहाँबाट सुरु भएर मैले अहिले चाहिँ यो बाँसबारीको जुन चाहिँ ऊ छ नि, यो कार्डियक सेन्टर भगवान् कोइरालाले भनेको, त्यतिखेर कार्डियक एसोसिएसन सुरु भएको थियो 55-56मा। मैले त 52 सालमै यो कुरा निकालिसकेको थिएँ। त्यसपछि चाहिँ नि त्यहाँ चाहिँ सुरु भयो कि यो जुन कार्डियक त्यो रिमोटिजम भन्ने त त्यहाँ त कन्सेप्ट नै थिएन त। पछि आएको, पछि चाहिँ नि भगवान् कोइरालाले त्यहाँबाट भनेपछि मैले यो रिमोटिक हार्ट डिजिजमा चाहिँ नि यति ठुलो काम, ओल्डलाई नै ठुलो काम पुर्याइरहेको छु है। बिरासलमा मैले काम गर्दाखेरि एउटा इनोभेसन मात्रै कुरा गरिरहेको, मेरो त सिधिसक्यो त समय त है कुरा गर्दै गर्दै, तर 15 मिनट बनाएको छ है मैले त है। त्यसबाट इन्ट्रा हेपाटिक खोलेलिथियासिस मैले पत्ता लगाएको छु ओल्डमै, intra hepatic cholecystitis.
May I request Dr. Pandey sir to limit in your presentation, sir? You are going to something.
ल ठिकै छ, ठिकै छ। अब यो रिकमेन्डेसनहरूमा पनि तपाईँले भने म अब मेरै उसमा चाहिँ लिमिटेसनमा जान्छु र यसरी चाहिँ नि तपाईँको अहिले चाहिँ नि ओल्ड वाइडमा चाहिँ नि यो रिमाटिक हार्ट डिजिज भनेको नेपालमा चाहिँ नि अलिकति यो हामीले दिनपर्ने कुरा के हो, फोकस गर्ने सबैले दिन फोकस गर्ने के हो भने टेम्परेचर। अहिले त टेम्परेचर परिवर्तन भइरहेको छ, फ्लक्चुएसन भइरहेको छ। बच्चाहरूलाई चाहिँ नि एकदम तातोमा राख्नुहोस्, बच्चा सधैँभरि तातोमा राख्नुहोस्, चिसो हुन नदिनुहोस्। चिसो हुन नदिएपछि चाहिँ के हुन्छ भने उनीहरूलाई रुवाखोकी लाग्दैन, रुवाखोकी नलागेपछि स्ट्रेप्टोकोकल इन्फेक्सन हुन सक्दैन, टन्सिलाइटिसहरू डेभलप हुन सक्दैन, अनि बच्चाहरू चाहिँ नि रिमोटिक हार्ट डिजिजबाट मुक्त हुन सक्छन्। यो मेरो रिकमेन्डेसन हो। मैले सायद अलिकति हार्स भन्छ कि के भन्छ नमिठो शब्दमा, अलिकति साइन्टिस्टहरू त यस्तै हुन्छ। अर्को एउटा भाइ त्यो अर्को एउटा के थियो नि, अर्को थियो नि एउटा चार्ट, ल उहाँले चाहिँ नि त्यो देखाउनु भएन। लास्टमा चाहिँ मैले के भन्छ एउटा राखेको थिएँ, त्यो आएन। सबै कुरामा चाहिँ के हुन्छ भने एकाडेमिकल हायरार्की मैले एउटा डेभलप गरेको थिएँ, जुन कुरा अहिले सरकारले मलाई भिसीमा रिकमेन्डेसन गर्दैन। यति चाहिँ भन्ने मलाई स्वीकृति दिनुहोस्। साढे चार्ट दिएको थिएँ, यहाँ राखेको छ, त्यो टपिक्स मात्र राखेको छ, त्यति भन्न चाहिँ मलाई चाहिँ स्वीकृति दिनुहोस् तपाईँहरूले। यो अलिकति मिस्टेक भएरहेछ। ओरिजिनल चार्ट मैले हिजो पनि आएर भनेको थिएँ, भएन। त्यसमा के लेखिएको छ त भन्दाखेरि नै यो त सरकार यो सरकारले, नेपाल सरकारले नै एक्सेप्टेसन गरेको कुरा हो। मैले त्यहाँ के भनेको छु भने मलाई भिसीमा चाहिँ अपोइन्टमेन्ट दिन खोज्दाखेरि मैले नखाएको कुरा, तिमीहरूकोमा चाहिँ हायरार्की पनि छैन, एकाडेमिकल हायरार्की, एकाडेमिकल लिडरसिप, एकाडेमिकल सिनियरिटी, एकाडेमिकल चाहिँ तपाईँको चाहिँ लेगेसी अनि डिसिप्लिन हुनुपर्छ है भन्ने नि किसिमले मैले चाहिँ एउटा यहाँ दिएको थिएँ, त्यो रहेनछ। र अर्को पटकको लागि चाहिँ नि सायद तपाईँहरूलाई मेरो कुराहरू सुन्न योग्य लाग्छ भनेदेखि यो नेसनको लागि असाध्यै चाहिने चिज हो, जुन कुरा यो कन्फरेन्समा पनि मेन्टेन भएको छैन। हायरार्की एकाडेमिकल भनेको साह्रै सेन्सिटिभ कुरा हो। जसले पनि त्यो डिसिप्लिन मेन्टेन भएन भने जसले जे पनि गर्न सक्छ, खाओस्टिक बन्न सक्छ, अनि त्यो फेलर हुन्छ। अनि इन्टरनेसनल लेभलमा चाहिँ नि त्यसको रिकग्नेसन हुँदैन। इन्टरनेसनल लेभलमा के अरे रिकग्नेसन भएन भने हाम्रो यी सबै कामहरू चाहिँ निरर्थक खर्च मात्रै हुन्, ड्रामा मात्रै हुन्। यति म भन्छु। अरू कुरा त तपाईँहरूलाई चाहिँ साह्रै दिक्क लाग्यो होला, म धेरै डिस्टर्ब गर्नु पनि चाहदिनँ। मैले जहाँ जहाँ गए पनि मैले इनोभेसन काम गरिराखेको छु र इनोभेसन काम गर्नुपर्छ। यो तथ्याङ्कहरू कहाँबाट बटुलेर लिएर आएर के गरेर प्रेजेन्ट गर्यो त्यो रिसर्च होइन। किनकि सिग्निफिकेन्ट भेल्यु भनेको 95 भन्दा माथि अथवा बराबर भएपछि मात्र रिसर्च योग्य हुन्छ। यहाँ त मैले के देखेँ भनेदेखि 50 0मा पनि थाइल्यान्ड पनि त्यही रहेछ। 0मा सिग्निफिकेन्ट भयो हुँदाखेरि पनि उसले चाहिँ पिएचडी गरेर आयो है। ल यति भन्दै मैले माफ मागेँ, तपाईँहरूलाई मैले बढी बोलेँ कि के गरेँ।
Thank you, Dr. Pandey, for your presentation. So we have another slots of the presentation here in the same hall, and in the meantime we have a very delicious lunch awaited for us. So with the interest of time, without further any delay and undue, now I would like to request presenter Buddhiman Shrestha sir, please to be in a time frame, and for my technical assistance team, please cope up with the presenter slide.
Thank you, chairs. Good afternoon, everyone. My topic is assessment of oral health status among rural population of Nepal. As we all know, oral disease is a major health burden for many countries, affecting many people throughout their lifetime, causing pain, discomfort, disfigurement, and even the death. It affects nearly 3.7 billion people. And according to WHO Prevalence of Oral Disease 2019, prevalences of untreated caries, deciduous teeth was 51.2%, permanent teeth amongst 5 years and above was 31.5%, prevalence of severe periodontal disease in people above 15 years was 14.8%, and prevalence of edentalism in people above 20 years was 1.4%. I think everybody has, most of the people have this type of problem, and this is the dental caries is one of the leading causes of toothache and dental health problems in worldwide. The most common problem according to WHO report in 2022 were untreated caries lesion, periodontal disease, edentalism, and cancer of the lips and the oral cavity. Due to educational, cultural, and socio-economic burdens at present, the prevention and treatment of oral disease is virtually unavailable to the rural and unprivileged population, although significant amount of dental problems has been identified since the commencement of National Oral Health Policy in year 2004 AD. अब म चाहिँ खास गरेर यो रिसर्च किन गरियो भन्ने विषयमा, since no any research has been done in past regarding the oral health status of Manang people, this study will provide us a baseline data regarding the oral health status of the people of Manang, and so that preventive as well as curative programs can be planned in near future. The main objective of this research were to identify the prevalence of dental caries, similarly the prevalence of gingivitis and periodontal disease, and determine the prevalence of edentalism among community people of Manang to determine the oral hygiene knowledge and practices of community people of Manang. A descriptive cross-sectional study was conducted in Chame, Manang district. After taking ethical approval of IRC committee of KDC or Kantipur Dental College, informed consent was obtained from each participants before participating them in the study. Those participants who were willing to participate in the study were included, and participants below 15 years were excluded. And the convenient sampling technique was used for the data collection, and sample size was only 250. Data was collected using a standard questionnaire which was administered to the participants by a single trained dentist. The first section of the questionnaire consisted of demographic details, and the second was about oral health, behavior, and knowledge. And the third section, the questionnaire was related to oral health care seeking and access. Similarly, the fourth section questionnaire had oral health assessment section, which was adapted from WHO Basic Oral Health Survey Form 2013 for adults. Data was entered in AP data and analyzed using SPSS version 21. Descriptive statistics like percentage and frequency were calculated. Chi-square test was used to test the association of variables, and P less than 0.05 was considered statistically significant. And coming to the results, altogether 250 participants were there, and mostly the 165 were female and 85 were male. The mean age of the participant was 48.4. Majority were Mongoloids. You can see the age-wise distribution of participants is adult, mostly the adult 176, which was 70.4%, and older adult 65.26%, and youth, similarly adolescents were only 1.2%. And similarly, most of the participants, that was 49.6%, were illiterate, and 18.4% is a primary. Similarly, 13.2% is secondary, and 12.8% is a higher secondary level, and above than diploma was 6% education level. According to job category, almost 49.6% was involved in farming. Similarly, 16% were in business, and government job 11.6%, unemployment 4.4%, others 19.6%. When asked about oral hygiene practices, majority of the participants, they use toothbrush to clean their teeth, which was 236 participants, and majority 231 use toothbrush and toothpaste. And apart from toothbrush and toothpaste, 200 participants, they didn't use any other oral hygiene aids, which we recommend to use interdental aids to clean the in proper way. And brushing frequency were, as you can see, once daily. 141 participants, they do brushing once a day, and 78, which was 31.2%, they use brush twice a day, and then 4%, they never use brushing, they never do brushing, and 8.4% is occasionally they do brushing. And I think everybody knows about the importance of the fluoride in dentistry, and we recommend to the people to use a fluoridated toothpaste. And here in this study, we found 113 participants. They use fluoridated toothpaste, whereas 104 participants non-fluoridated toothpaste, and participants 13.2%, which was 33 participants, they don't know about the fluoride. Similarly, tobacco consumption habit was found in 37 participants, and alcohol consumption habit was found in 105. Coming to the care seeking and access and the reason for the past dental visit, 120 they never received oral health education, and 150, which is 60%, thought oral health affects general health. They also know, they know about it. And on question related to the care seeking, seeking and access 175 dental visits the past, and the 75 they never visited dentist. And majority of the participants who visit the dental clinic because of the pain due to caries, which was 84 or 33.6%, and for tooth extraction 65 participants, and remaining for other reasons like prosthesis and general checkup. And when we asked why don't you visit the a dental clinic, they say most of the like 45% to 45.2% respondent, they said too expensive dental treatment is, and few 39.2% due to the distance, and you can see other like even they don't give the importance, which was 1.6%. And we found dental caries 75.6% in the, which was in 189 participant, edentalism 145, gingivitis we called dantaharsa 95, 4 to 5 mm pocket 67 participants, 6 mm and more pocket in 11. Similarly, partial denture wearers in 26, and complete denture only 2. And you can see gender-wise comparison of gingival status and periodontal status, which is gingival status showed no statistically significant association, and but in a periodontal pocket they have showed statistically significant differences, which was it is our team in Manang, and we had organized the dental camp over there. Coming to the conclusion, the findings of the study show that the oral health, of course, in residing Manang was very poor, and for the improvement of oral health of those people, government should plan and organize oral health awareness and the dental camps on regular basis, and the government should make oral health services accessible for those people by involving the local governments. And for this, I would like to thanks to everyone. सबैलाई भोक लागेको छ, खाना राम्रोसँग चपाएर खाऊ. Thank you so much. Thank you.
Dhanyavad. Thank you very much, Buddhiman Tamangshir, for your outstanding works carried. Buddhiman Sresht, sorry, for outstanding works carried out in the Manang districts, and highlighting the urgent essence of the oral health care and the oral health service packages available in the all level of government. So with this, all the presentation and keynote speech in these sessions, now it call for the only 2 or 3 questions for the floor discussions. So shall we go ahead? So धन्यवाद. यस ग्रुप बी सेसनमा विभिन्न विद्वान महानुभाव अनुसन्धानकर्ता विभिन्न विज्ञदाताहरूले दिनुभएको उद्वेलित प्रवचन प्रस्तुतिले हामी सबैलाई एकदमै गर्मजोसिलो बनाएको छ. पक्का पनि यसले नेपालको स्वास्थ्य नीति र कार्यक्रम तय गर्ने सवालमा यी विषयवस्तुहरूले महत्त्वपूर्ण योगदान दिनछन् भन्दै अब विदाउट भेरी अनड्यू केही छ भन्ने राख्नु होला, मैले धेरै कुरा बोल्न छैन.
उपस्थित सम्पूर्ण महानुभावहरू, यो राम्रो प्रस्तुति भयो र त्यसमा पनि आज यस्तो संयोग मिल्यो क्लिनिकल साइन्स र आयुर्वेदको आज इन्टिग्रेटेड रूपमै एउटै प्लेटफर्ममा प्रस्तुत गर्न पायौँ र आयोजकले हामीलाई चाहिँ यसो यहाँहरूको यस सेसनको अध्यक्षता गर्ने अवसर दिनुभयो. त्यसकारण आयोजकलाई धन्यवाद दिँदै सबैजनाको प्रस्तुति राम्रो छ र त्यो प्रस्तुतिले अवश्य नै यो सेक्टरहरूको विकास विस्तारमा मद्दत गर्नेछ र हामीलाई धेरै कुरामा हामी पोलिसी मेकरमा बस्ने, डाक्टर साहब मन्त्रालयमा पनि डिपार्टमेन्टमा बस्छु भने हामीलाई झन् यसले चाहिँ यो इभिडेन्सहरूको आधारमा हामीलाई चाहिँ काम गर्ने झन् हौसला प्रदान भएछ र यो क्षेत्रहरूको कार्य प्रगतिको लागि हामी चाहिँ प्रतिबद्ध हुनेछु भन्ने कुराको जानकारी गराउँदै हाम्रो धन्यवाद है तपाईलाई.
Okay. Thank you to all our presenters for sharing your work with such a clarity and passion. Now I would like to invite our session chairs to present a token of appreciation to each presenter As I call your name, please come forward to receive your token and also wait for a while for a group photo at the end. Miss Usha Singh. Okay. Dr. Satya Narayan Yadav. Dr. Jaya Satyal. Mr. Bipin Ghimire. Dr. Binod Kumar Yadav. Dr. Lily Rajbanshi. Dr. Nisa Acharya. Dr. Lakshmi Prasad Ghimire. Mr. Dev Raj Pokhrel. Okay. Dr. Bisun Dayal Prasad Patel. Dr. Nirmal Bhusal. Dr. J.N. Pandey Himali. Dr. Buddhiman Shrestha. A heartfelt thank you to each of you for the dedication and efforts you have put into your research and presentation. With this, now I would like to request Dr. Hari Prasad Dhakal, member of Executive Board member of NHRC, to come on a stage and present a token of appreciation to our session chairs. Also, I'd like to request all the presenters to join on stage along with our respected chairs for a group photograph. That brings us to the end of this parallel session. We look forward to seeing you again after a launch as we continue with more engaging session. Have a pleasant day and thank you once again.